O'r adabam, Dan Williams, dwi Cadeirydd y Bwrdd, y Corff Llywodraethu Iechyd Proffesiynol Bai Abertawe. Mae'n bleser gennych gydeirio cyfarfod y bwrdd bore heddiw. Croeso cynnes i chi gyd. Croeso mawr i'n gwestiwn. Penny Cresswell Jones a Kimberly Can gan Iechyd Cyhoeddus. A croeso arbennig i Jackie Davis gyda ni am y tro nesaf. So, good morning everyone. I'm Jan Williams. I'm the chair of the board, the governing body of Swansea Bay University Health Board. And it's my pleasure to chair the board meeting this morning. Warm welcome to everyone, and a particular welcome to Penny Cresswell Jones and Kimberly Can from the public health team. Lovely to have you with us. And we pay a particular welcome this morning to Jackie Davis, whose last board meeting it is after an 8-year term. Or do I say sentence? We will return to that at the end of the meeting. So Swansea Bay University Health Board is a strategic population health body, and we do have a statutory duty around health protection and public health. So our board paper,
Waiting downstairs.
no problem. Oh, come on. Pat, come and sit here. Come and sit here, Pat, say the words. No problem. Very well. The Mo, Nathaniel and Claire Taylor, and chair our stakeholder reference group, and Claire is contracts. So I've just started, so we haven't missed anything. Just saying that Swansea Bay is a strategic population health body, and we do have the statutory duties, whether that's around health protection and public health. So our board papers all have a population health dimension to them, because one of our strategic objectives is that the people of Swansea Bay live healthier, equitable and more equal and prosperous lives. And today we're taking a look at what the wide variations in the uptake of screening services mean in respect of achieving that objective, particularly given the scale of deprivation and disadvantage we have across our population. So Swansea Bay provides health services for around the 400,000 people who live in Swansea and Neath Talbot, and for many more for some of our specialist and regional services. So we spend £1.765 billion of public money. We employ 13,500 full-time equivalent staff, and that makes us one of the largest public bodies in the UK. Now, as the governing body, the board's the highest level of decision-making. We normally have bi-monthly meetings, and this is one today, when we cover the breadth of our agenda. We are committed to conducting our business in public session and to openness and transparency, and we are very happy to hold ourselves accountable. We do have a specific section on governance, but we need to ensure good governance across everything we do. And that's all forms of governance: corporate, clinical, financial, information, cyber, climate, all different types of governance. And we also have to keep our eye on risk, which we do throughout the meeting. Now, our board committees play a key role in discharging a lot of business on behalf of the full board. And you will see reports from our committees across the agenda as committee chairs and lead executives alert the board, assure the board, or advise the board. There are some matters that the board has to discharge itself, and we have 4 particular organisational objectives this year set for us by the Cabinet Secretary around planned care, urgent and emergency care, primary care, mental health being one, programme commitments. Then, as you know, we took a special board on the 15th of July to receive and accept the independent review of maternity and neonatal services, and the board has to oversee a robust approach to implementing our improvement plan. And then we have to really look at mental health services, and we have a transformation programme underway there, with a paper on our agenda. And then our fourth organisational objective is around our joint working with Hywel Dda. So the board itself has to keep oversight of that. Now, the board works within three timelines: the here and now, the intermediate, which takes us around 3 to 5 years, and then the longer term. And always on our agenda, there will be some items that cross-cut these timelines. And that's the case today when we look at the update on mental health, when we take our strategic equality plan, when we take our planning and partnerships report, because of our fundamental role in building and sustaining strategic partnerships. And it also applies to our paper on the fifth LINAC in support of radiotherapy service. They all have long-term implications, but they need our attention here and now. So on the board's current agenda, we will be continuing to look at primary care. We began last meeting with a look at general dental services, and we are continuing with general medical services today. And there will be a read across to our population health agenda as well. And we have a rolling programme now as a board of looking at primary and community services. We will be taking an update on planned care, where we continue to do extremely well. And we do have some very welcome news around improvements in unscheduled. We've had to put some money into unscheduled care to secure these improvements. And that's not something we've done lightly, because the board is very well aware of the significant challenges we face. We know that we are overspending, and we know that we have to take some very uncomfortable action to put that right. And the Chief Executive has sent a very strong message out into the organisation yesterday around that. We know we have to do better, reducing our run rate and increasing our recurrent savings. But we also have to look at safety, quality of services, access to services, and the management of risk alongside our financial position. We have to take it all in the round. And that's what the board does. And today, for example, we're taking a specific look at insourcing some more access to first outpatient appointments, because that is a key requirement of us. But we never put performance ahead of stringent financial discipline and management. We take it all in the round. So with staff, the board actually sets the tone and culture for the organisation. We always have a section on people, but of course, we always think about the implications of what we're doing on our staff. And we always have a patient or staff story, because we need to remind ourselves why we're here and the purpose of what we do. And then at the start, the Chief Executive will also set out the key issues that we need to take into account as the meeting goes on. So that's the background, and I'll turn to the agenda. And in terms of apologies, Richard Thomas, we think, is en route to Japan, and Joe Albert-Davis is with us. And Chris Morell has also left the country, we think, and Alison Clark is with us there. And then we've had apologies on that. So are there any declarations of interest, please, outside those already on the register in relation to today's agenda? Thank you. So Abby, at that point then, I'll hand over to you, please.
Thank you very much, Chair. And I will take a moment to pick out a couple of the areas within my Chief Exec report. So colleagues will be aware this is an opportunity for me as the accountable officer to just draw out some of the key issues, particularly in relation to where we are in escalation. Many of the items are covered in depth in our paper, but it's an opportunity at the beginning of the meeting for me to set out some of the kind of important components of the work that we're taking forward. Colleagues will know that we're in a level of escalation for the targeted intervention for a number of our services, and we had a change in escalation status recently as a result of the independent review in mater and neonatal services. Just to let colleagues know, we had our latest quarterly meeting with Welsh Government, which is chaired by Judith Paget, the Chief Executive of NHS Wales and Director General for the Department of Health and Social Care. and children and young people. This week, it was an opportunity for us to walk through all of the levels of escalation to give Welsh Government colleagues an update on the work that we've got in train to progress towards de-escalation in those areas. It was a useful meeting. I think it was a constructive conversation. We had a comprehensive set of slides which we will share with independent board members who won't have seen them. That was as I said, it was a constructive conversation. We have an escalation framework. It has been updated to reflect maternity and neonatal services and the de-escalation criteria. And Liz in particular is just working through with Welsh Government about making sure that those de-escalation criteria are the right ones. It was also really important for us to reflect back to Welsh Government our desire to make sure we've got one improvement plan for maternity and natal health services, so not something for the escalation and not something separate following on from the arrangements we've had in place. And that was supported and welcomed by Welsh Government too. So that's really, really helpful to us moving forward. So just turning to maternity and natal local services, Jan, you mentioned the board meeting we had, the special board meeting we had. Very grateful to Jo and the team who've been working with Ken Sutton around how we ensure that women and families shape our improvement programme and work with us on an ongoing basis in terms of strengthening how we do engagement right across the board as an organisation, and that work is progressing, and we've got a paper on that coming through, and we'll make rapid progress with implementing that. And colleagues will also be aware that the Cabinet Secretary has announced an All Wales assessment. And just to say that that's very helpful to us. It's helpful that Welsh Government are looking to mirror some of the approaches that the independent oversight panel has used in our review on the national work to make sure there's sort of alignment with that, and therefore an expectation that Welsh Government, because of the comprehensiveness of our review, won't need to do the same level of assessment as they're doing in other health boards across Wales, and we'll be very close to that. And then the only final thing to say on maternity and neonates, we will be continuing to work with the oversight panel as we discussed in the last board meeting, and Welsh Government has indicated as part of the targeted intervention arrangements they would like to have sitting alongside the oversight panel and part of those meetings an independent perspective from Welsh Government. We're not quite sure what that who that individual will be and what type of appointment the Cabinet Secretary will want to make in that space. But clearly, again, that's helpful to us to have another channel into Welsh Government from the oversight panel. And the chair of the oversight panel is involved in those conversations as well. So it's another point of triangulation in terms of the work that we're taking forward. And of course, we are working hard to progress the areas that we identified as priorities in the last board meeting, and we'll bring a more comprehensive update back in September when we've started in earnest to pull together the improvement plan. And as I said, we're not waiting for all that work to come together. We are cracking on with the things that we know we need to do immediately, thinking about your time horizons, Jan. Just a couple of other things then. Mental health, we've got a paper coming later on the board meeting, which again I think is really helpful. Colleagues will be aware that NHS executive came in to do an assessment of our mental health services pretty much alongside the work that Melanie Walker, our special board advisor, has been doing. And just to say, we had a meeting this week with Welsh Government and the performance and improvement team. It's taken longer than we anticipated, but there is a report that's now being finalised, and we will bring that back to the board in September. There's nothing new in it. There's nothing different to what Melanie Walker identified in her initial assessment. And again, agreement that we'd have one improvement plan, so it would all be under our transformation programme rather than a separate response to the recommendations coming through that. And again, Welsh Government confirmed that they were happy with that proposal, which I think is really helpful to us. I won't steal the thunder about emergency and urgent care, but again, what I did want to say is that I'm really grateful to Deb and the team who presented to the 6 Goals programme a couple of weeks last week. Yeah, that's what it was last week. I've had feedback from a number of colleagues who've wanted to reach out to us, to say, well done, it was a really good presentation, But just as we've been going to look at other places around what we can learn from other places, some colleagues are asking us to share what we've been doing in that space. So, and you'll hear more about that later on in the agenda. John, just two final other comments, if I may. Picking up on your introductory remarks, John, about the financial position, just to again restate that. As part of the targeted intervention meeting, of course, we talked about the financial position and the balance we need to take about safe patient services, delivery of performance, and we made it very clear in the feedback to government as part of that conversation that it is not an either or. We fully understand and are enacting the fact that it is a financial position and delivery of the performance, and we fully accept and are working on that basis, and just wanting to reassure Welsh Government that is absolutely the board's focus, and that's the focus of the executive team and our service groups too. So it was a useful opportunity in the targeted intervention to feed that back. And then the final thing I just wanted to pick up, organising for success. We are progressing that work under Tina's leadership around the shape of the organisation, the design of the organisation, and we are keen to learn from other organisations. Some of us had an excellent visit to Somerset Foundation Trust yesterday. They're similar to us in terms of being one of the only integrated organisations in England. So they are a mental health provider, community services provider, acute service provider, and particularly around mental health services. There was a lot for us to learn, and also about how they organise themselves and have structure. Again, there's quite a bit for us to learn, but also around how the board gets oversight across all of the issues. We'll probably go back with Liz and Hazel to have a further conversation about that governance, but it was really helpful in terms of how the chief medical officer in their organisation, so the equivalent of Richard's role, ensures oversight when you're covering so many areas, and need to have the kind of specialist input around things like mental health and primary care. So much for us to take away, and a desire to share that learning, which was really helpful to us. So thank you, Jan. Happy to take any questions on the other items as well.
Thank you, Abby. That's covered a lot of ground there. So Nicola, please come in.
Well, thank you, Chair. Thank you, Abby. Just a quick question about A&E, if possible. It's obviously been about 6 months, I think, since the staff came in and shared their harrowing story with us. Obviously, there's been some incredible work that's been undertaken in the meantime. I just wanted to have a little bit more information, if possible, about what work we have done to improve services there, and just wanted to ask really how staff morale is now, please.
Yeah, thank you. I mean, Deb probably want to come in just very specifically on the two colleagues who came to join us. One of the things we are working through at the moment is to use one of the board development sessions so we can have a longer immersive piece on this, and to bring those colleagues back as part of that, and to hear from some of the other colleagues who've been part of leading the change, seeing the change, and that we do that in the October board development session. So you'll have an opportunity for hearing a lot more about it. But Deb, do you want to say a little bit more? We've got colleagues joining us a bit later on to come and give us a bit of a presentation, and we might want to ask them to reflect that back as well, kind of from the front line. But is there anything else you want to add, Deb?
Yeah, I'll start with a shameless plug. It'll be on BBC News at 18:30 this evening. And as well as me, there are some interviews with the staff who BBC interviewed in January, who you'll recall gave a really concerning picture of what it felt like to work in the emergency department, and their reflections are very different this time around, which is really positive. And we purposely chose the same staff so that they had the opportunity to give an open and honest review of what that looks like. Overall, the feedback from staff is really positive within the emergency department. They feel able to do their job, and they now feel less pressured coming into that environment, because it's always a pressured environment in the emergency department. You know, it's never calm, or it shouldn't be, because that's what it's there for. But they feel now far more comfortable in that environment and able to do their job. So we've had nothing but positive comments from the team in the emergency department. That said, the unscheduled care system is broader than the emergency department, and there's still work to do in the other front door sides of that. So the acute medical unit is where we would go next, because that is as pressured in terms of capacity as the emergency department is. So that's where we're going to go next in that space. But overall, really, really positive. I won't steal the team's thunder on what we've done, if that's okay. But if there's any questions at the end of that when they give the presentation, I'm more than happy then to pad it out. But I think you'll get what you need there. It's a combination of lots of things, and I know it's been, the change in performance has been very quick over short space of time, so the last 8 weeks, but it's a culmination of lots of things that have been going on prior to that, that we took the opportunity at the beginning of June to make a big bang approach, because we had a ward area that became available to us to really make the difference in that space. So that's why it's so quick this end, but it is, there was lots of things going on. It wasn't, we did nothing before that, it was just all coming together nicely.
So you can hold that and come back to it. Abby, do you want to?
It was just following up on that, just to let the board know that Liz and I, with Sue Moore from the service group, met with the RCN a couple of weeks back. They had done a health and safety visit to the emergency department, where some of the things that we'd heard previously about staff concerns and wellbeing and sense of safety were raised with us. So we do have an action plan. They gave us some comments back around how we could strengthen that, which I think were fair observations and comments back. We've agreed to strengthen the sort of partnership working in collaboration, and I know we're doing work to strengthen the health and safety team in the organisation as well. One of the things that came out when the staff joined us and came up again in the meeting with the RCN was around security presence. I know that we've worked hard to increase the presence within the department. We have given a commitment to looking at benchmarking and whether we're a complete outlier in this and how we deploy the resource that we've got to best effect. And we will go back to the RCN and provide an update on that. So it's still a very live issue. And obviously that is a group of staff who are seeing people in their most vulnerable and most stressed and traumatized. And clearly reducing weight helps with the stress and tension. But I think the other thing, there was a really stark message about our ED was designed to have spaces for 64 in the unit at any one time, and we've been running so far over. And again, giving assurance that the agenda around replacement for the ED is still something we absolutely need. So it's not, oh goodness, we don't need that anymore because we've managed. We absolutely need to make sure we've got the right spaces, and we still haven't got that, even with the decongestion that we've got. So again, continuing to push very hard and as fast as we can in the design of that, and hopefully securing capital funding to enable us to have what we need in that space. Thank you.
Thank you, Abby. And Jean, I know you're looking at the reset of Quality and Safety Committee approach to health and safety as well. So if we can remit oversight of this to you and the committee, please, as the action plan develops on that. Thank you. And Nuria, I think you wanted to ask for an assurance paper around item 10.
I do, yes. As you know, there's been the High Court decision on Emirates, and we've been looking at the audit committee as oversight of that relationship. So it would just be helpful just to get a paper to the audit committee that just explains what's happened and an update of where we are at, so that we know the position in terms of where our relationship stands. I think that would be really helpful.
Thank you. Nuri, with EMERTS specifically, or with JCC, or a bit of both?
I think a bit of both would be really helpful. So
Yeah.
yeah, just to understand where we're at. I think
That's really helpful. It was one of the things I was going to say, and then I was conscious of time, so I didn't. But we are looking at the hosting arrangement, because clearly we host. So we've got two relationships in here. We've got one as a commissioner through JCC in the commissioning of the service, which is obviously a hybrid model between the charity and EMERTS. But we're also looking at the hosting arrangement. Our reflection is it's probably too loose. We've picked that up as part of the looking at our portfolios, and we have got conversations with Ross Whitehead, who is the commissioning director for emergency transport services, to look at that, because I think we probably need to move it away from a hosting arrangement in the way that it's currently set up. And we're very happy to bring a paper back once we've done that work and brought back options around how we strengthen that, either strengthen hosting or it becoming a service that we're directly commissioned to deliver. And I think the arrangement between the charity and the EMERTS service also needs to be strengthened. I think that's been recognised by JCC, so thank you for raising.
Thank you very much. So thank you, Abby. We'll accept your update and everything that's in your report. And thank you very much for bringing those matters to our attention. So we move now to our risk register and our board assurance framework. The board is still at work on refining risk appetite, and we will be having a board development session on that in October. And of course, we take a great interest in and close oversight on all aspects of the risk register. Hazel, shall I hand over to you, please?
Thank you, Chair. So as members will be aware, we're going through a risk management reset at the moment, developing a strategic risk register, corporate risk register, and then operational risk register with that golden thread through the risks then. We're hoping to start in September reporting to the committees the more operational risk linked to the corporate risk register and the strategic risk register then as well. We are working with the Good Governance Institute to help us support in that work, and also the risk appetite, as Chair just mentioned. This report presents the current Health Board risk register, which contains 32 risks, 20 of which are at our risk appetite. We are taking a look at the risks in there in terms of the wording, just to make sure that they are clear. There's 2 risks that have been added on since the last report to board, relating to timely clinical coding completeness and risk associated with the cost of replacement of pathology system. We've also presented today the risk management policy for approval. It's been through the risk management group, management board and audit committee as well, Chair.
Thank you, Hazel. Before I open it up, Abby, just want to say something around the risk now relating to maternity neonatal services and where we are following receipt and acceptance of the review.
Yeah, thank you, Chair. I think this builds on what Hazel was saying and your introduction, Jan, that this is work in progress in terms of getting this right, in terms of what we should have on here are, in terms of our strategic objectives as an organisation, the things we are most worried about as an organisation that create risk in terms of delivering safe patient care. And reflecting on this, making sure that we are adequately reflecting in here the current position in terms of risk around maternity and neonatal services, which may not necessarily be about operational delivery, but it's about actually our risk of being able to deliver all of the recommendations. Liz, you might just want to comment on that. And my other observation would be, you know, we are looking in depth at our mental health services, and it's not just about the estate and the physical environment which we're providing, it's about having a fit for purpose service that can meet all of the needs. And it feels to me that there's a risk around the pace at which we can deliver the transformation. When you look at the inquest coming through, when you look at our Regulation 28 prevention of future death reports, our ability to move at the pace that we would want for that transformation. So we will take those things away as an exec team and make sure we're properly articulating those in the risks and get a sense of where they should be in terms of our scoring. Because if you think about our agenda, it feels probably not quite right that we haven't got those things reflected in terms of the priority we are giving them. Liz, I don't know whether you want to say anything more about maternity and neonate.
No, as you say, we're working through what that risk is, or what the risk to us is, and it is about delivery of those recommendations and our improvement plan. So we will take that through and we will put that onto the risk register for board in that context.
I'll open it up more broadly then. Jean.
I did mention this at performance and finance. I really believe that this visibility now of the risk right the way through every register we hold is something that gives us all clarity of where we are and what we're doing. I observe, though, that we might not have the correct scoring in terms of the appetite that the board has for risk. And one of the things I was slightly perplexed about, which I think Deb was going to take away, so perhaps she'll respond to my question, was we had cancer monitoring now included in planned care, and yet planned care has been reduced from 16 to 12. To me, as an IM, that doesn't make sense because of the performance in terms of the cancer monitoring. To reduce that score to 12 didn't make sense.
No. And it's sorry, Chair. And it's something we hadn't considered, to be totally honest with you. So we've included cancer within the planned care from a programme board perspective, because it is a part of planned care. It's not an unscheduled care, and it's only the tool really that we should be measuring. The delivery side of it, I think, can be separated because we are delivering on, because the targets are so different and the services are different. the delivery is therefore different. So I think we need to be very specific from the risk register perspective of what we are including and what is excluded. So I will pick that up with Hazel and the team.
Thank you very much, Sam. Deb. That's really helpful. So I've got Nuria, then Anne Louise. Nuria.
We discussed the risk report and the framework at length in the audit committee. We did receive a reasonable assurance rating from internal audit, which I think is worth mentioning. I think that there is a lot more work, and Andrew was part of the committee, Patterson with us, you know, please chip in. I think that there's a lot more that we felt needed to happen in terms of understanding what we're tolerating and the likelihood of these risks actually already materialising and living with them. I think there is a bit about wording. The point that Jean made about planned care was made in the audit committee too, in relation to sustainability of the low risk, given into account the audit bills report, which touched on our ability to sustain our performance on the long run. So I think there's a lot more work. We also queried the EDI rating going down, given that it was just discussing some of the areas that we are testing, but not necessarily implementing. So are we living with the risk at this moment? So I think that there is a lot more that we can do. I think it's heading in the right direction. I think it's fair to say, but I think the more we challenge ourselves in that mitigation space and in the likelihood and in the scoring, the more we will ensure that we have that oversight as a board of where the risks that we're actually tolerating lie.
Yeah, thank you, Nuria. And I think it does stem from the board having another look at its risk appetite, doesn't it? And then
Yeah.
scoring the specific risks follows from that. And Louise, I'll just ask Andrew if he wants to add to that, picking up on Nuria's point before I ask you to come in. Andrew.
Yeah, I think it's been good to see improvements in how the risks are being managed. But one of the things has been the framing of some of the risks, I think. And occasionally I think a change in the wording about what the actual risk is would actually help to clarify what the actions required are. And so I think there's a bit about more clarity and understanding that, which would help the scoring, I think, and allow us to get to that sort of gut feeling that the right risks are reaching the top. So I think there's a bit of refinement to it.
Thank you, Andrew. And Louise.
Thanks. I've got a query about two of the risks. One is the clinical coding and what the language that supports its appearance in this, because it's a high risk. It's been awarded of 20, and yet it's obviously been something that's been a fact that's been known, that the A for C banding in Wales is different from England, if I've read that correctly. And consequently, we're losing staff. My understanding was that clinical coding has an increased importance now for us to be able to understand what we're doing. And yet the scoring, perhaps it might be hardly recognises that this is an area that is going to be difficult to tackle given our financial issues, because it's clear that more money is needed to be able to recruit at the right level, to get the right people in to do the right job, to be able to inform the health board. So I'm just wondering about that. And the other one is the bugbear that keeps coming up on the Mental Health Legislation Committee at risk 43. It's been downgraded from 20 to 16, and I just wonder whether it should be on at all, because this is something that's been going on since 2017, and it's come up and up and up. And we haven't recruited more best interest assessors. There are breaches every time because they're raised at the Mental Health Legislation Committee. There may not be very many, but they're still breaches. And if there are breaches, there are patients, because each one represents a patient. And I think if we're comfortable with that level of breach, why have it continuously on the risk register? Because an observer might think, well, why have anything on the risk register if it isn't dealt with in whatever 8 years?
Thank you. Thank you, Andrew. With very pertinent points there. I'll ask Andrew and then Matt in respect to clinical coding.
Yeah, so on the clinical coding risk, I think there is something there about rewording some of the risk to focus on what the actual issues are that we can address. But we are monitoring the Digital Data Committee, and there is a plan in place to address the recruitment issues and the wider issue about how do we get the coding up to date, which Matt will correct me if I'm wrong, has been included within the financial plans. So there's a way of doing this because of the change in technologies to be able to address the staffing issues at the same time as not exceeding the financial envelope that we have to do it. So there is work going on to address the issue. I think probably one of the frustrations is it's not quick enough. So we're also looking about how do we address what are the fundamental issues that we're trying to get at, which is, as you say, the understanding of the data for analysis in the future, and what can we be doing in the meantime to address that problem in perhaps different ways and different approaches. So that is on the agenda each time the digital thing.
I'll ask Matt to come in, then I have Nuria, but first to say that Matt and I went to TSAMLA yesterday afternoon. And I sat down with 2 trainee clinical coders whose training is 2 years. And, you know, there are 77,400 codes. Now, clearly they don't have to memorize 77,400, but there's an enormous amount of work associated with training, taking a very complex theory and practical exam. And the next exam is not scheduled till March for these 2 particular trainees. And Matt and I had a good conversation with a number of qualified coders and the issues facing them. So I came away with a very different perspective on everything we're expecting from clinical coders, and both, you know, what the banding ought to be, but then how quickly we should be moving to AI to actually support this. But it was, I would say, and I would, for me yesterday, just sitting down with them and understanding what's involved. Matt, and then I'll bring in Nuria.
Thanks, Chair. Excuse me. Yes, it was a very worthwhile visit, wasn't it? And so I think on a number of things that Andrew has said, thought always goes wrong with those. So we're moving on those number of actions. We've just done a consultation process with the staff to take forward this rebanding change aligned to the work around the AI approach. So that's the model that COMT have taken forward, whereas they've rebanded their staff to more of an auditing role of what the AI is applied to the data rather than 100% coding. There's still going to be a mixture of both elements to the role for a number of years to come as the AI model advances. And I guess we put our plan forward a number of months ago, which described, as Andrew said, the way to get back on target, but it is going to take, as it stands, 2 to 3 years to get to those targets. There are issues across Wales as well, so we're not the only health board. So together with the other organisations led by DHCW, a project's been looked at what we can do to get to where we need to get to faster. Clearly appointing more trainee coders and getting them trained is part of that. But that's going to take time as well for them to be fully qualified. What we could look at doing in the meantime is to reduce the breadth of the coding that we do against each episode to maybe just focus on primary condition and primary diagnosis to get us back on track. And if we did that, we could be back up to 81% by the end of this financial year and soon to 98% within the next financial year. There are things we need to consider if we were to do that, and we're considering them at the moment. Jan and I had some feedback from the coders yesterday in terms of some of the risks that would be involved in not having that full breadth of coding against certain specialties, etc. It's something that we're actively looking at. We are planning on putting a paper back to next management board to describe that. So we may be able to accelerate what we did put forward as a plan a couple of months ago, but we do need to make sure we're aware of the risks of doing that.
If I could ask another question on that, Jan, is there anything we can offer the staff who are doing this that would keep them with us rather than them continuing their training, be trained, and then go to England where they get paid more because the rebanding is taking such a long time? Are there any inducements that we can provide or offer to just make sure that they stay with us?
I think that's an absolutely valid point, but I think the fact we just I think we're just pretty much through that consultation process to agree that upgrade from the band 4 to band 5 for the right level of coders is going to happen over the coming couple of months.
As long as they have some security knowing that that's going to do, because if we're spending all that time training them, we need to keep them. Thank you.
Nuria, Deb, then Jean. Nuria.
I don't intend to prolong this any longer. I just wanted to make the point, just for reassurance, that we did also touch upon the subject access requests where that risk is actually materialising in real time. So I think it is important that we raise that. I think that the fact that we're having this discussion is really good in terms of improvements to our risk register and the risk and the assurance that we need to support. But as you can tell, there is a lot of risks that we are tolerating where we will come back to you to ask questions around the wording in relation to the mitigation. And I think that's precisely what this shows, I think.
Thank you. And that speaks to Anne-Louise's second point around the best interest assessors. Are we going to tolerate this? Say formally, we are tolerating this level of risk with the impact it's having on patients. So I'm ask Abby to take that one away with the executive team to look at that. Then,
Both of those points, if that's okay, Chair.
Yeah.
If it's on the clinical coding question and the English problem we've got, it is a very real one because the reason our staff moved to England to code is it's all digital and it's all at home. So they don't have to move to England. So the sooner we digitise our records, it gives them more flexibility at home working, reduced costs. I know because my daughter-in-law is a clinical coder. She works for Colchester and she lives in Aberyron. So they do it all remotely. So we've got to move with the times a bit more on clinical coding to secure our workforce at the right rate of pay as well. And you're right, Jan, it's an incredibly complicated exam that those teams do. I think it's been undervalued in Wales for a long time. Just on the best interest meetings, particularly in mental health, one of the issues that drives this, it's the choice issue and the impact on patients and families as a result of whether a patient is eligible for CHC funding or whether they aren't. And we're doing an awful lot of what's called a DST assessment, so a decision support tool assessment, which decides whether a patient is able to qualify for CHC funding or not. And we're doing those in our hospital beds when we shouldn't be. So those DST assessments should be done at the next point where the patient is moved into a different environment. That's what we've got to pick up with local authority colleagues and with families and patients to manage their expectations. And obviously they would all prefer to have CHC funding because we fund it then rather than. So it's work we've got to go through. It's work we're picking up with Hazel and the legal team that we've got. It's all around, the choice at what point do we intervene. When do patients end up in the court of protection because they don't want to do what we need them to do? So there is a lot of work to do on the whole thing rather than just the best interest. So I think we probably do need to review the risk and how do we make sure that it's real with problems that we're facing within the system across the patch.
Yeah.
Jean, would you like to connect that?
Deb's just very eloquently made my point because we cannot continue to tolerate the risk. We have to put pace behind the resolution of this. And the pace can be injected via the automation and the digitisation of what we're doing, I believe.
So I think we obviously receive the updated register, Hazel, and I think we can take assurance that the whole agenda is moving in the right direction. However, we need far more assurance around things like the framing of risks to make sure we've actually got them as they need to be. And what is the categorization of risk then? If we take, terminate, tolerate, transfer, treat, etc. Where are we on some of these risks? So we will need to bring that back. And it all needs to be set in the context of our updated look at the risk appetite. So we can have a big piece on this at board development in October, if that's okay. And then the risk management policy, Hazel, you still need that approved, recognising this is dynamic. And as we develop and make this work more sophisticated, we may well come back to that. But as a working document, we can approve it to enable Hazel and her team to progress. Thank you. Thank you for a very good conversation, very insightful comments on that. So Liz, I'm now going to turn to you for our patient story, given that, as I said in the beginning, it's really important that we just remember why we're here. Over to you, Liz.
Yeah, thank you, Chair. We actually have two stories today, and it's from parents of a baby that was born with us, and it goes to share what we offer beyond birth beyond that initial delivery of the baby and the care afterwards. And it's actually about our health visitors. And I think sometimes we forget we've got a whole team of health visitors out there who are helping us and will help us with population health and development and really reaching into our communities. So we're going to hear Anne Harrod's story first, and then we're going to hear Josh's story.
I was informed that I'd need to be induced at 37 weeks. And for me personally, it was a big shock because I technically lost so many weeks in work because I planned on working right up until the very end. I personally felt really stressful because I didn't have that time to mentally transition not being in work and, being a parent that bit sooner. So very fortunate, healthy delivery with Dexter. And then when we had our first initial meeting with the health visitor, Jane, she shared with me lots of groups that was happening in Swansea. First one being a baby massage group, and it was something local that I could walk to as well. So that was something I joined. I met Jan, who was facilitating it, and she was really welcoming. And something I always found that for each of the groups I have attended, there's always been the opportunity of a round robin. So that introduction of yourself, your baby, saying how old they are. And that's something I always found was really positive to see, not just young babies being there, but older babies. And it was something positive for me because I thought, well, these mums and dads must keep going back. These groups must be very beneficial. So I started with baby massage, found out more about other groups. My next one that I started on a regular basis was a walking group that was along the seafront. And that was something we always met at the same point at the same time every week. And that's when I found that, Jan and Becky were really supportive in helping me become friends with a lot of these parents, because it's not just mums, there's dads there as well, which is great. And really learning about me, learning about my interests, my goals with Dexter as well, being a mum again, and seeing what opportunities were there in me developing friendship groups amongst what was walking group to begin with, but then soon developed to be the sing and splash sessions, continuing with baby massage, and then rhyme time, these so many different community groups that were accessible for everyone. I never felt, being the first time going to the rhyme time, not feeling left out, but straight away involved, like I could really participate in each of these groups. And then just making those friends over time, and just kind of stepping away from that safety blanket and putting yourself forward in speaking to other parents, how are you finding being a mum, and those conversations starting, but also with the support of Jan and Becky there as well to sometimes help start those conversations. But no, with the support from Jan and Becky, it could be very much, I could be asking them questions about, baby-led weaning, because I would see that other mums were talking about it, and just them having that, those skills to say, oh, Anne Harrods, come here a minute. I've just been talking about this with so-and-so. Do you want to ask them? And, it's to really give you an opportunity to start building those relationships. They've listened to me as part of my journey of becoming a mum and attending these groups. And I found, they've always shown an interest in me, in Dexter, in my family, and that does go a long way. Other things I would say about them is just this, they're so welcoming. I can't praise them enough. A thank you as well for them both, because if it wasn't for them too, I don't think I would have made half as many friends as I have amongst these groups when attending on a weekly basis.
That's Anne Harrod's story. We're now going to hear Josh's story. And Josh is Dexter's dad.
Angharad was coming home a couple of times a week saying she'd been at various different groups with their health visitors and started talking about, you know, some of the conversations she had had, some of the experiences that she had had, what the weather was like that day, what the walk was like, and how her confidence was growing week by week by attending the groups. I work full time, so wasn't able to attend most of the groups. But what I had done was in my calendar, I would put whatever groups that Angharad was at, mainly for if I was trying to contact her for the day. I know I can contact her for a certain hour of the day because she would be at round time. She would be at baby massage, and I didn't want to interrupt those. So it started really by me scheduling my day around when I could contact Angharad and Dexter. And then I was off work one week and was invited by Angharad to meet her friends and the health visitors down at the walking group on a Friday. So yeah, I went along, was, you know, really made to feel welcome at the group, completed the walk, and then had a little coffee afterwards and got to sit and socialise a little bit more with new parents. And then from that experience, I had the confidence then to attend the group myself, because Angharad was on a keeping in touch day in work. And when I was on that walk, I think because I'd met people there before, I felt a little bit more confident walking into that setting. But the health visitors, you know, walked along with me for the first part of the walk, made me feel welcome, made me, you know, feel part of the group, and introduced me to some new people there. And then I think once they had seen that I was gaining in confidence or had something in common, or, you know, a conversation had started, they kind of drifted off a little bit, quite tactfully, to allowing me to walk with a new mum and to talk about, you know, a whole range of different things. So I think we first started talking about our experiences as parents, and then we went on to talk about what music concerts we were going to on the weekend, or, you know, little things in common that we kind of had, that we necessarily wouldn't have been talking about if it weren't for the walking group. And then I've attended Sing and Splash, so I'm keen on getting Dexter water confident, because, you know, I'm into surfing, and I hope that he would share my hobbies and interests in the future. So I want to get Dexter as confident as I can in the water. I'm not very confident in singing myself, but I've taken Dexter in the water, and I've, you know, done the actions, and I've done the nursery rhymes, and that's something now I'm off work, and I'm starting my shared parental leave. I'm hoping to take Dexter to particularly the Sing and Splash group and the walking group on a Friday.
I think it shows the range of services sometimes we forget that we offer, and health visitors facilitating those groups, which then wraps around support for new parents. For me, seeing that Josh was confident to go once he had that shared parental leave, I think we shouldn't forget that happens quite a lot. And it is quite isolating if you're on your own and you haven't got family around you. So I thought there were two stories that really showed the breadth of the support that we give to our communities.
Nicola, then Nuria. Nicola.
Jan, thank you, Liz, for sharing the stories. It was wonderful to hear such a positive experience. Having had a child that was in COVID, so I welcome these groups starting back up. I think they're so important. I also think the continuity of having the same health visitor makes a massive difference as well. So just praise to the staff. It's wonderful.
Nuria.
What a lovely story. It's absolutely lovely. It's great to see a lovely story, and it's great when when you know that a service is actually reaching our communities and engaging with our communities in such a way. I think it really talks to our population health agenda in particular, and our population health role. And we are part, like Nicola said, we're part of our communities. So it's fantastic. I think for me, it's about how do we utilise health visitors to their full effects, because they go to people's homes, they're our direct contact. So when you talk about asset-based building, place-based building, they are our eyes and ears into our community. So it's how do we get that intelligence through to help us shape our agendas and our thinking about our clinical service plan, all the things that we are excited, rightly so, about in terms of our transformation. That would be my only observation. But gosh, what a way to start the board. Thank you. What a treat.
Thank you, Liz, and convey our thanks, please, to the Health Visiting Service. We are, as part of our programme on primary and community care, going to take a whole agenda item on community services at a later meeting. So we'll certainly pick up on the role of health visiting there. But that segues very nicely into population. Oh, Rena, I can see you there. Do commence.
Sorry. No, just a quick one, Chair. I just was very impressed with the fact that Josh has been, if you like, encouraged to go along and is participating, because I think it is really important in the context of population health that we have fathers on board as well as mothers. And often the emphasis through things like antenatal classes and sometimes can be more on the woman, which naturally it would be. But I really do think in terms of, if you like, giving children the best start in life, the fathers have a key role in this. So it's important, and I was really pleased to hear that. Thank you.
Thank you, Irene. That's an important contribution there. And of course, it's something that came through very clearly through the independent review, the importance of partners and us actually recognising that. So nice segue then, Jill and Steve, into the whole population health agenda. And we do start with report from the committee first.
Okay, so there's one committee report to draw your attention to, the meeting on the 5th of June. IT's just closed down, so. Okay, thank you. So there were three alerts to bring to the board's attention. The first was in relation to the screening update within Swansea Bay. We've got a paper in the next section on screening. But what the committee was concerned about was the disparity in uptake of the screening opportunities and the poorer parts of our community tended to take the screening opportunity up much less, and those disparities are a concern. And the paper we're going to see in a minute will explain how we're seeking to address that. We then had a couple of papers on vaccination uptake. It's not referred to in the report, but one of the concerns that we had was that the vaccination uptake by our staff was quite low. And you know the implications of staff getting flu in flu season, and therefore not being able to go to work. And we've heard from other areas that we have a high level of sickness in Swansea Bay, and if non-partaking of flu vaccinations is contributing to that, then that's serious. But in the vaccinations to the general population, we are also below target. And we wanted to bring, and in particular, Jill wanted to bring attention to the board to the fact that if we ever do reach our target of 70% uptake across the board for influenza vaccination, there will be a significant financial challenge. And that's something that we should be alerting Welsh Government to, because the targets that they set, that comes with a financial cost associated with it, which is not currently being spent. And on the subject of finances generally, we've said to the board before in this committee that there is, in our opinion, an underinvestment in the population health agenda. We talk, and we are committed to being a population health body as a health board, but the investment we are making is below what would be ideal. And for example, I think it was pointed out to us that our budget for the population health team is about 0.02 of the total health budget. And there is a school of thought that we should be spending something in the region of 5% of the budget on prevention and public health matters. So that's something which we need to increase this investment over time. So those were the three alerts. Happy to take any questions.
Thank you. Jill, do you want to add anything to that before I'm going to chunk this up? Do you want to add anything first?
Just to say that there's a lot of work happening on the immunisation and for our staff. Paper has also gone to the Workforce and OD committee on that, and so we keep the board updated on that as they would like. Thank you.
Rena, I'll ask Tina to come in first in the question of the ward work around uptake rates for staff first. Is it okay?
There's just an observation from the board paper, in my role as the observer as well, in that maybe the wording that we've got here, it says that you have received assurance around the staff flu vaccine, then we considered the same report at the ward committee. We raised that as an alert because we didn't feel we were assured from the resources that we've got, and that particularly the increasing in the vaccination rates that we need to achieve this year for staff. So we've requested more information to come through for that. So I think again, it's how we link in across to the committee to make sure we're getting the same level of assurance through.
Yeah, that's an important point. Then, Rena, do you want to add to that?
Yes, just to say that obviously we did consider it at WAD last time round, and in particular we were a bit concerned that the plans in place were not sufficiently, if you like, in terms of coverage for things like peer vaccinators being in place and the sessions within the different settings. So I'm hoping that we will have a follow-up report in August, which will give more assurance on what we are doing to get the vaccination rates for our staff up. Thanks.
Thank you, Rena. Abby, do you want to add to this?
So I was going to come in on a separate
Oh, right, okay.
separate item. So I don't know if anyone wants to respond to that because we really do need it. It's a really important intervention, isn't it, in terms of health.
Yeah, Rena, and thank you to Liz in particular and Chris and others that have been working on the peer vaccinators. We're up to 80, so really, really good progress. And I think we've had a lot of our venues are identified. There's still some venue identifications go, but we'll certainly update Rena. Yeah,
Thank you. Jean, do come in.
Yeah, thank you, Chair. If we're talking about the resource being an issue, do we have worked out plans as to what that resource should look like? Or are we merely making the statement that we're under-resourced? Do we know where we're under-resourced? And by what? And for what?
Abby, do you want to go in on that one first?
Yeah, we need to have a look at this, Jean, because there are two things to me. There's the specialist support we need in our public health team and resource, and then how do we move the organisation more into the space that every contact counts, prevention is everyone's business. And I was just pulling up my chief exec report around the ministerial advisory group, the cabinet secretary's priorities around getting services ready for the future. You know, we've talked about, you know, the move from illness to wellness. How do we get upstream with prevention, as well as more into the community and more digital and less analog as part of that process? We need to look over time, and Darren might want to talk about this, about how we articulate what our early intervention prevention offers. I spent some time with the therapies team in the last couple of weeks, and again, just hearing from them about the prevention work they're doing, the work they're doing in primary care around primary prevention and how we can support that, so things like the diabetes work to get people off a pre-diabetic pathway and reversing that, looking at things like the work that our therapists do for secondary prevention. If someone's had a stroke or had an MI, for example, how do we stop that happening again? Because we're intervening in a teachable moment in someone's life about doing something different. So we need to reflect on this around how we capture how much of our activity is in that prevention, early intervention, working out primary care. Our kind of neighbourhood modelling clusters should all be about how we can get in there early, what primary care can do, what our community assets, what the third sector can offer. As we heard, I'm sure some of the groups that young families go to will all be third sector, well, some of them will be third sector groups, for example. So we need to stand back and do a piece of work on that, because I don't think we could say it's more than the number you talked about, because what you were talking about, Steve, is the team, which is probably too small, and we do need to make sure we've got the right skills. But it is about how we think about this being a population health agenda right across what we do, and that's hard to do, but it's something we need to do. And Darren's been giving some thoughts to how do you do that overall and over time, so that we could describe being able to change the shape of our organisation to reflect that. And that for me is hand in glove with the primary care piece, because that's most people's contact is out in primary care. And a lot of what we do in primary care is all about prevention and early intervention. And we need to think about how we do more of that and shift more out to the community to enable us to do that. So it's work in progress, but a really important point to focus on. Thank you, Chair.
Darren, then Nuria. Darren.
Yeah, thank you, Chair. We'll hear later about maybe an existential problem of the financial challenge of the board, but it shouldn't stop us addressing this. Our future financial sustainability and our duties in terms of population health will come from this work. And we have to run them all together, so we do have to bear down the cost of the organisation. But we also must do these things to strategically position as well. Myself and Hugh Thomas, who's my counterpart in our session last Friday with our finance teams, looking at how we allocate resource in the future with some experts from England, some health economists came to talk to us. So we've got some ideas that probably in the next month or so, month or two, probably we can bring the board members to show how we might do that. And we can link them with children colleagues as well. But we really must give this our full attention, aligned with the other challenges we face.
That would be really helpful. And Jill, perhaps you could bring some further detail, because when these vaccination, immunisation screening programmes are set up with a percentage population coverage, they are designed to be preventative. So therefore, they're designed to prevent costs further down the track. So, and that cost benefit analysis is done very carefully. So perhaps through the committee, you could give board some more information around that. Would that be helpful? Thank you. Thank you. Nuria, please come in.
I think Abby pretty much covered all of what I wanted to say, but I think that there is two really important points here, and it's that distinction that we've made at the very beginning between the team and the population health agenda. We did receive a limited assurance report on this issue, and that goes around our implementation of the population health agenda and our ability to implement that. Some of the issues that we've just discussed today would go to address some of the findings in that report, but what I would like us to urge us to do as a health board is to use the opportunity that the clinical service plan will bring for us to actually look at population health with a different lens in terms of understanding the needs and looking at the model that you brought to the Population Health Committee in terms of, I can't remember the name, Joint After Health, that's it, in terms of how that fits in with where we are as a health board moving forward. And that's very much what Abby has described, which is understanding our primary care and how that fits in. I just wanted to make that point because I will be referring to the limited assurance report on population health later on in the agenda.
Thank you. And Nuria, I'm sure Marie will be referencing the population health strategy increasingly from now on as we take the planning and partnerships work forward. So we're going to move to a specific paper on screening services. In respect of the uptake rates for vaccination, can I ask for a joint paper from Water and Public Health Committee, Population Health Committee, please? Because the two come together, so avoid duplication. And then Darren, as you said, we will be coming back to the whole allocative process in terms of when we get the overarching 1.765 billion, then, you know, the substrata of allocation. Because just to flag, I'll be asking later on, how much do we actually spend on cancer? And screening is cancer prevention, which is incorporated in that. So they will connect, don't they? So I will be asking that question. So thank you, and thanks again to Steve and the committee for the alerts you've raised there. So that does take us then into our screening services paper. Jill.
Thank you, Board. I'm going to be assisted in this presentation by one of our consultants, Kim Khan, who has really produced the excellent epidemiology, which you can see in the report. But just first of all, to set the scene is that cancer is something that will affect, 1 in 3 of us, and it's something which 4 in 10 cancers are preventable. We know that cancer affects those in deprived areas most, that the earlier you catch a cancer, the better for your chances of survival with a good quality of life. And that also in deprived areas, there may be delays in people presenting or in people being heard. So screening is an essential public health tool for a population health strategy to detect cancers early so that they can be treated early. And therefore, it's really important that we look at our uptake across all of the deprivation quintiles. So over to Kim for the epidemiology.
Thank you, Jill. Good morning. I'm Kim Khan, consultant in public health. This paper focuses on the status of the uptake of screening services locally, with a particular focus on the disparities in our population. As Jill referred to, cancer is leading cause of death in Wales, and we know that maybe 4 in 10 cases could be prevented, and that mortality rates are significantly worse in the more deprived areas, and that gap is increasing. The Audit Wales report highlighted that 24% of our cancers are diagnosed at stage 4 and 18% at stage 3. And mortality significantly increases the later the stages of diagnosis. And screening plays a key role in identifying cancer early. The Public Health team have been working collaboratively with Public Health Wales screening engagement team to develop an action plan to look at health inequalities locally. But I'm going to start with a bit of the local status and epidemiology and then hand over to Jill for next steps. We've got 7 national screening programs in Wales. 6 of them are delivered by Public Health Wales, and 3 of them focus on cancer. The first one being Bowel Screening Wales. We've got about 32,000 people in Swansea Bay who take up the offer of bowel screening each year, which is about a 65% uptake. It's a bit lower than other health boards, but not statistically significantly so. We do have a significant gap in health inequalities. The most deprived areas have 57% uptake compared to 72% uptake in the least deprived areas. There's also variation by age, with younger age groups not taking up the offer as much. To put that into context, we know survival from bowel cancer is lower than across Wales as a whole. And generally trends across Wales in under the 5-year mortality, 5-year survival from bowel cancer is decreasing in men under 55. And when we look at Breast Test Wales, breast cancer screening program, we've got about 13,000 women each year who take up the offer, which is a 73% uptake. It's the highest health board, but there's still different gradient in deprivation. So, for example, the most deprived, only 64% of women take up the offer compared to 79% in the least deprived. Uptake's again, lower in younger age groups, and particularly women who haven't attended for the first time yet. And to put that into context, our 10-year survival is significantly lower than Wales as a whole, but our 1 and 5-year survival rates are significantly higher. And there's a general increase across Wales as a whole in the last 8 years in survival. Our third cancer screening programme is Cervical Screening Wales. You've got a coverage of 69%, which is very similar to Wales as a whole. And when we talk about cervical screening, we talk about coverage because it's those eligible to be screened who are screened compared to the other screening programmes, which is proportion of people invited who are screened. There's again a gradient of deprivation. We're talking about 63% uptake in our most deprived areas compared to 75% uptake in our least deprived areas. We've got a 5-year survival rate that's significantly lower than Wales, but a 1-year survival rate that's significantly higher. And worth noting that the NSC, the National Screening Committee, has recently approved home testing kits for those who don't take up their offer for the first time. And the 4th screening programme, which isn't yet in place but is worth highlighting, will be lung screening. The recommendation for a national pathway for lung screening has been accepted by Welsh Government, and Public Health Wales have been tasked with planning with what that will look like. And lung screening will be a key issue because our 5-year and 10-year rates, survival rates are low, but our 1-year survival rate is high again. And health inequalities in survival in lung screening, lung cancer are particularly high in Wales. I've also included in the paper a double aortic aneurysm, the AAA, which is a screening programme, and diabetic eye screening Wales. I don't know if anyone would like to ask any questions before I hand over to Jill for next steps.
Okay. I find the report really interesting. Thank you for that. One of the things I looked at, and I know that you say challenges to improving screening uptake is the delay or the lag time in which you receive statistics. But I thought it would have been really helpful to set into context the annual figures that you provided, where we do had a trend analysis over the last 5 years, say. So to enhance the report, maybe there's an opportunity for us to review that kind of statistic.
Happy to do that.
Got Nicola, Richard, then Anne-Louise. Nicola.
Oh, thank you. Thank you very much for the report. Found it really interesting to read. Quite disappointed though, obviously, with the uptake, especially in the deprived areas. What work are we going to be doing in our primary clusters and with our partners, potentially within the PSB space, to encourage screening, vaccinations, etc.?
So if I could come to that in the next section of the report, but if there's any more questions about the data.
Hold that, Nicola. Sort of, Jill will come back to that. Richard, do
Thank
come
you.
in.
Thanks, Sharon. Thank you, that's great. It's a very good report. On diabetic eye screening, can you check meaning that refers to coverage rather than uptake? So the numbers that are quoted, is that what we mean by coverage as opposed to uptake?
It's uptake.
Same.
It's the same.
Thank you very much.
Thank you. Anne-Louise.
I think we'll probably will either touch on or cover my question.
Thank you. I think as well, I'll just add one point on that. If people come into it for everything, it all depends on the initial contact they have and how positive or otherwise that is, and particularly something like diabetic eye, as to whether they ever come back. And I think that is something that we do need to take into account when we're thinking about it. See? Yeah.
Exactly, putting people at ease and
So next steps then.
So work that's already underway in Swansea Bay. And just to put this into context again, we have a vaccine equity strategy for Wales. We don't have a screening equity strategy for Wales. So that is currently a gap, which we'll be looking at with Public Health Wales. But it's essential that we do mirror the approach that we've used for vaccine equity. So the screening engagement team at Public Health Wales have been engaging with us locally and have been working with Swansea and Neath Talbot Council, also with the community connectors and certain groups such as carers and LGBTQ plus groups. They have done some work with, I think, minority populations, but nowhere near enough at this stage. They've been working with some primary care clusters in Neath Talbot and Penderry to discuss how they can improve uptake locally. And they've also met the women's group in the city cluster. And clearly this does align with the women's health priorities that we know are being taken forward through the home. There is a screening engagement lead in the team for at University Health Board, who liaise with us. She's just 2 days a week. So we're actually asking for more time because we believe that we really need to tackle this issue. So we have also been working with our vaccine team, our vaccination team, who have much more experience in vaccine equity and in inclusion health. And so they have been advising as well. And we will be looking at using their approaches, their networks, because they already have them, and also some of their resources with regard to a pilot on phoning patients who haven't taken their offer. So that there are some data issues about that, as you might expect, but you know, those shouldn't be a deal breaker, and we should be able to do some telephone follow-ups. So we are also looking at working with the screening division on the opportunity of the lung cancer screening pilots, and knowing that that's probably going to be piloted actually in Clontarf, but we need to do the learning early here and look at how we can embed, if you like, before it even starts, the approach to ensuring everybody accesses, regardless of where they live and what educational level they have. So often these offers are accepted by those who are already health aware, and it's actually those with very low health literacy that we need to approach, and that is a much bigger task. So if you like, the whole of the work of the population health team is about health literacy. That is also health visitors are part of that, and other professionals. So health literacy and making every contact count is also a key plank of any strategy for anything in this area.
And Joe, Nicola's earlier point about using partners like public service boards, etc. How are we going to be engaging?
Well, we will be engaging through obviously our existing partnerships, and there are subgroups of the PSBs that we need to make sure that they're aware, and also the RPP, which Marie co-chairs, that they're aware of this being an issue. So we would quite like this paper to go to our partnerships where they can see the stark differences really, and it's something that populations are unaware, aren't they, of this, and it's only when you actually reveal it as a sort of epidemiological analysis like this you can see. But if we overlay that with the vaccination paper, it's just a consistent message as well, that it's all health prevention initiatives that need more focus.
So I've got Jean, Joe, Abby, then Anne Louise. Jean.
Sorry, Chair, I should have been more diligent in reading my notes and then you wouldn't have had to come back to me. But one of the things I intended to suggest was that we utilise the learning from the maternity review in terms of engagement, because there's a vast amount of information there as to how we can move forward with that visibility in the community.
Yeah, it's a really important point there, and particularly as we are reshaping our whole family and the community engagement mechanism. Joe.
Yeah, and it was just building on that really, was just to reflect that obviously we have our diverse outreach workers which sit within our Council of Voluntary Services. One of those is specifically commissioned to concentrate on vaccinations and screening and update advice. We're looking as part of the reshaping about how we can actually develop that model further, so there may be further opportunities there. And I think, again, it's down to that. We are out as part of the general engagement, the continuous engagement we do with the voluntary sector and everything. I think we could probably do more about being clear about some of those messages in a concise way so that we're delivering them again every time we have contact with any part of the community, or whenever we're going out to the Phoenix Centre or whatever, then we can pick up those messages. So I think there's a real opportunity to link those two things across more strongly.
Thank you, Joe. Abby.
It follows what Joe was saying, really. When we went, Liz and I, to the local mosque, on the back of some of the follow-up engagement from maternity and units, there was a real open door. And I think some of those community leaders that are not necessarily sat around the table in formal partnerships give a real opportunity. Certainly there was a really very warm welcome to come in and talk about other things and provide access to some of the communities and help us understand how we get better access to some of the communities. So it was really positive. Thank you, Chair.
Anne Louise then. Yeah, Anne Louise.
I was very struck by the stark statement that overcrowding, the risk of cancer is 7 times that of the usual population and 3 times in social housing. And although, Jill, you've mentioned partnership with the local authorities, I wonder how energetic they are in looking into the housing deprivation areas because of the effect on the population, and also the education authority in terms of what is taught to the children in their, I can't remember what it's called, but their sort of health and social care lesson for the uptake, because I think children take that message home to their parents as well if they're properly taught, and it's an area for school nurses as well. So I just wondered what comment you have about what they're actually doing, because it's all very well to acknowledge there's a problem. It's a different matter to actually be able to do something about it.
Yes, and I think, obviously I'm not in the local authority, so maybe Nicola may want to come in as well, but I know that there is a gap in a way in terms of the curriculum about self-care, looking after yourself. We of course do have our Healthy Schools programme to look at the whole school approach, but actually the education of the individual. And one of the things, if you look across as well at the the vaccination programme for human papillomavirus. Basically, we have low uptake there as well. So, which also affects boys, of course, and we know that if we can immunise those who are late teens and get them up to a high coverage level through our school nurses, but also, through messaging and health literacy for the young people, then they will be covered from a lot of the HPVs that cause cervical cancer, head and neck cancer, etc. It won't, currently the vaccine doesn't cover absolutely all viruses that do cause cervical cancer, sadly, but there are other vaccines coming down the road that will. They're not currently procured, but we do know that the hope one day was that we would be able to stop cervical screening. But clearly, until we can immunise, fully, but we can reduce hugely the numbers of cancers if we, push that HPV vaccination programme. So our vaccination team would really, and already are engaging, obviously, with the education and parts of the local authority, but we really would appreciate dialogue on HPV in particular.
So I've got Nuria, Keith, Richard, and then I'm going to ask Abby to bring this one to a close. Nuria.
So this is clearly incredibly important, and I think it's really important on lots of different fronts. It does require a multifaceted approach, and it's complex, and it requires that understanding of what place really looks like, the trusted sources of advice that people go to, and that can be hairdressers, for example.
Yes.
So it's about understanding what works for our communities.
And they did it in Brazil.
Absolutely. One of the key issues here, I think, for me, is that ethnicity and understanding ethnicity, because we know that in terms of outcomes, cancer is one of the areas that we need to target. But for me, this is about our broader strategic approach, and particularly given the strategic quality plan that we're going to talk about later, it's about clarity that delivering one size fits all doesn't necessarily deliver equal outcomes. And I think that it's about how we're able to bend and reprioritize our programs and services to deliver those equitable outcomes. And I think that's the move that we need to discuss as a board and where we go forwards with the agenda. So it's hugely important. I just didn't want us to lose sight of that bigger strategic picture in terms of our resources and how we program bend to deliver that equity agenda that we want to see and those outcomes that we want to see in terms of health.
Thank you, Nuria. That's an important point to link it with the strategic equality plan as well. So Keith, Bernard, you come in.
It's a fascinating report, and I agree with all the points that have been raised so far. I'm looking at the financial implications section. I mean, as a board, we talk a lot about moving to a population health model, changing the shape of the organisation. Yet when you get to section 4 of the paper, Public Health Wales National Screening Engagement Team have a 2-day-a-week post to cover Swansea Bay. And then there's a tantalising sentence a bit later, we believe there's more local support that could be given. Would you say a little more about that?
Yes, certainly. I mean, we are hoping to be able to progress Band 7 posts, but as you know, the situation in the Health Board is currently really at a crisis point for the overall finances being meeting our Welsh Government targets. But if we are able to advertise those posts, we do have 2 Band 7 posts that will be dedicated to the equity, the vaccination and screening side. So thank you. In time, there is a plan for increasing, but we are also putting quite a lot of pressure on Public Health Wales because we believe there is more resource that could be used to help. And they're incredibly engaging with us. So, thank you for the connections, Dan. We are having progress in those negotiations.
I'll ask Abby to say more about that at the end as well. But Richard, I'll just bring you in.
Thank you very much. Yes, there were 3 points of questions. So the first was about, and they've all sort of been touched upon, The first was about the reasons why people don't attend. And while there's things like the hairdresser and the rest, if ultimately it's people are afraid of cancer, afraid of the diagnosis, don't want an unpleasant diagnostic test, which they know is coming their way if they called it. It seems important that when we do that and when we do engage, we also seek that dialogue with people with feedback as to the reasons why they didn't attend, because that might in some areas be public transport to get to the test, it might be childcare, it might be any number of different things, but I think there's a richness in the information that we could collect ourselves to understand the population better. That was the first thing. Secondly, I was just going to ask, so of the modifiable determinants of health, only about 20% related to the health system. And if we get under the bonnet of cancer, a lot of cancers are caused by environmental factors, smoking, environment, employment, etc., that aren't necessarily related to health. Are there other government departments who have targets set on cancer reduction in part of how they contribute to the overall cancer agenda?
But it would be an excellent thing if they did. But smoking is the greatest cause of, the greatest preventable cause for cancer. So smoking cessation is the other huge plank in a cancer prevention strategy. And I think that, your first point was well made as well. And there's been a lot of insight work that has been done centrally by the screening engagement team. And sometimes it is out-of-pocket expenses at the timing of appointments, but that's the beauty of a service delivered in general practice for at least the cervical screening. But it is difficult for a busy mum to get away and to avail themselves of those appointments. So that's where, we do need to make sure that services are being offered in a timing and a way that people can access, so that it's after school pickup, etc. And people have got jobs as well. So, but there is also, insight about there's this immunity factor that, it won't happen to them, it didn't happen to their mum, it didn't happen to, so. But what's different, of course, is the exposure to the human papillomavirus that they may have had with more sexual partners than their mum. So it's difficult, but there's health literacy. It's the whole thing is health literacy, really.
And then just one more, if I may, to touch on Keith's point about the financial implications. Is there evidence, recognising that in order to reach those more deprived communities requires different strategies, different approaches. Is there evidence that in health systems need to provide screening, effective screening for deprived populations that costs those health systems more than it would to the least deprived? In other words, you've got a higher proportion of deprived populations in your area actually delivering those screening services and the access to required actually costs more.
I imagine there would be, but I will look.
Thank you. But we talk about public service boards and the regional partnership board, but of course, our stakeholder reference group, you have a number of partners around the table with you. Would you find it helpful if this paper comes to your group to have a wider conversation on it?
Yes, I think this is something we definitely need to have a briefing on the paper. One of the things I was also thinking about was I know that we discussed when we were looking at the membership of the group, whether adding poverty specifically as one of the categories, because actually the experience of living in poverty is hugely complex, and I don't think any of us, unless we've been there, can understand it. And I was wondering, as we were talking, I know that the independent members represent a whole range of different things, but I don't know if there is somebody who represents the experience of living in poverty and represent deprivation at this board.
Well, Nuria is an anti-poverty campaigner. Nuria?
I am. And my background is in tackling poverty and social exclusion. That's my passion, and that's what I spent my career doing. I think that you make a really good point, but you need to remember, Pat, that poverty is not just you start in poverty. Poverty can sometimes appear even in people who have paid jobs. They can find themselves, for whatever circumstances, out of poverty. So it's a debate that's been happening for a very long time amongst the anti-poverty groups, and it's just that recognition that poverty comes and goes sometimes in people's lives for different reasons. So I can tell you I don't know everybody in this board, but I can tell you that the likelihood is that somebody at some point in their life has been in a financial situation which probably hasn't been ideal.
So, thank you, Nuria. So Pat, we'll take an action, we'll share the paper, and then one of Jill's team will come and talk to the stakeholder reference group. That's all.
Yeah, that was great.
Thank you very much. Abby.
Yeah, so thank you, Jill and Kim, for the presentation and the paper. It's really excellent. This gets to the heart for me about being a population health based organisation with an integrated care system. Two comments. Firstly, just to expand on what Jill was saying around Public Health Wales, and we are working very closely with Tracy Cooper, the Chief Executive and Head team, about looking at the region, the conversation we've been having through the regional committee about regional health economy and what that looks like and what that means for our population, but also teasing out more explicitly where they can help us. So we talked previously around the help with the counterfactual. So if we do nothing, this is our trajectory in terms of demand that will flow from not getting upstream in early intervention and prevention, and looking at the behavioural science around this, Jill, and getting into the detail of that, reflecting on the different needs of our different communities and populations. So it's that we are applying our knowledge to help improve access in particular communities. And then the final reflection is just coming back to this bit about being an integrated health board. I have seen in other places where you really join up. So if you take colorectal cancer, that's one where we could be almost eliminating colorectal cancer, or certainly catching it so early that we can intervene very quickly. And I think we do need to look at the power of the colorectal surgeon saying, I would quite like to be made redundant and not have to be chopping out your bowel. And I've heard a very passionate colorectal surgeon talk about going out into schools, secondary schools, and saying, please get your mum and dad, please get your granny and granddad, because this is why it's really important, and helping with that message sort of from the other end about seeing, I know we're all scared, we don't want to find something horrible, it's not, some of the more invasive ones, it's not, we'd rather not do it, but actually the importance of doing it and seeing it from the other end, about just how grim it is to have cancer treatment, how difficult it is to go through a cancer diagnosis, and really thinking about how we can use the weight of all of our voices in this. So it's I can see an opportunity for doing more of that and bringing some of those folk, Richard, that come at the other end of the spectrum into the early intervention space in a different kind of way. So we'll take that as well, John.
Yeah.
Thank you very much.
Well, Kate, we'll have to bring this to an end. And Kimberly, thank you so much for all the work that you've actually done in preparing paper and for all the epidemiological expertise you bring. And we know that we will be remitting to the Population Health Committee the ongoing work associated with the programmes, as well as ensuring, and Marie, I'm sure you will, the population health strategy, all this work around prevention will be sort of tied in ever more closely into our planning. And Deb, can I just give you a sort of a thought there to say, primary care, fundamental role here, of course. So the GMS paper later, because our deep end practices will be in these deprived and disadvantaged communities. Yeah, okay. So we'll receive the report, and really we can receive it, and with concern in respect of the significant disparities and variations in uptake, access, and therefore outcomes. And that really impact adversely on this particular strategic objective, which we need to focus on. So we clearly will endorse the emerging plan that we have, and we'll want to support that fully. As we said, we'll take it through to the Population Health Committee. But Marie, we'd also ask you to sort of take it into the partnership arena, please. And that segues very nicely into your piece on planning and partnerships.
Beautifully done, Chair. Thank you very much. Yes, so this is the second planning and partnerships report that the team and I have produced for updating the board on the activities that are going on in the planning commissioning arena. It is very broad, covers a huge range of strategic and tactical planning activities, partnership working, and down to very specific specialised in commissioning arrangements and progress as well. So Apologies for the length of the report and the range of appendices, but there were quite a few things that board just needed to be flagged to board colleagues for your awareness and for assurance. I won't go through the report in detail. I'm sure you'll be relieved to hear, so that will hopefully give us more time for questions. But I'll just step through very quickly through each section just to give you a flavour of where I want to draw your attention. So in terms of the strategy and strategic programmes, board colleagues will be aware that we have done some work collectively around the refresh of our organisation strategy, which we intend to launch at the AGM in September. So the feedback that we had a couple of sessions, then we had final feedback at our last board development session, which has now been built into the finalised plan, which is now going for production and translation, development, an easy read format, etc. So that will be formally launched in September. We've set up a process now to commence a high-level strategic clinical services plan that we are hoping to conclude the high-level strategy document to have it ready for the end of this calendar year. And we walked through the process last time. I won't touch on all the other parts, just to draw your attention to the annual plan refresh. We've got in one of the appendices, I think it's Appendix A, we've just got a timeline that describes how we get from where we are to an updated plan for next year. I think what's really important to emphasise is we don't have an approved plan for this year. It's not approvable. We are a way away from having an approvable IMTP. We know that. One of the things we've acknowledged in terms of process that we absolutely need to strengthen is how do we bring our service, so how do we bring that population health lens into the process in a meaningful way? What should we be doing completely differently? How do we use our partnership working to deliver on that? How do we bring together the work that we're doing in some of our bigger programmes around our areas of risk and mental health in MATNEO, in our planned and scheduled care programmes? How do we make sure that we bring those key delivery priorities into that space and then align them with what we can afford and what we can deliver with our workforce in a much more meaningful way? And in order to do that, one of the things we've built into our approach this year is to have an integrated quarterly planning and performance review. Where have we got to in terms of what we said we'd do in the plan? What's that delivered in terms of performance? What does that mean then in terms of our workforce sustainability and our financial sustainability? We're not there yet, but what we want to do is stop having everything done in separate silos. We do finance here, we do performance here, we do workforce over here, planning's over here. How do we, quality and safety is in a different place. How do we bring that all together at senior leadership level and look at where have we got to? What does that mean? How do we take that forward in a meaningful way? So in our first session, trying to take that approach last Friday, it was a bit clunky, I think, Deb, wouldn't we say, exec colleagues, but it's given us a platform on which to build. So I think we've got a new approach which will mean we'll stop doing this stop-start thing every time we do a new annual plan, because it's not new, it's the same thing. We've just got to make sure it gets real traction and delivers where it needs to. So that was just a quick update. So there's a timeline that's included in Appendix A that sort of steps you through the key milestones, but essentially those quarterly sessions are going to be a really important part of how we tie everything together, as well as our standard set piece kind of leadership meetings as well. Then in terms of partnership planning, so you've got a very detailed, at Appendix B, a detailed list of the RPB area plan priorities and delivery actions. It is enormous. The agenda is enormous in the RPB arena. One of the conversations that Deb and I had as this report was being prepared is we are spreading ourselves and our teams so thin. There are things here that we need to look at. How do we perhaps slow them down a bit? How do we refocus? Where are we going to put our energies, given that we are all in very difficult positions from a sustainability perspective? We have got care being commissioned in the wrong places. We've not got right care being provided. We're missing opportunities for intervention. We're absolutely missing opportunities around more closely integrating how we work. And so we agreed in a timeout yet to go through the RPB to be ratified, but you heard it here first. We've said we need to have 3 key priorities that we're driving on for this year. One of those is around older persons and frailty. How do we work more collaboratively in that community space to look at how do we improve prevention and how do we improve discharge collaboratively in partnership in that intermediate care or integrated community care system arena? How do we address collaboratively the things that we need to do together for mental health services across the system? And we know that there are huge opportunities there to strengthen the way that we work, and some of the things that Deb, Abby and I and Richard and I saw yesterday when we visited colleagues in Somerset were really, really helpful. Some eye-opening stuff there that we can build on. And then the third one is around long-term and continuing healthcare. We know that those are areas where we are hemorrhaging funding, and we are not meeting service users' needs, either in the local authority arena or in the health board arena. We know that's a complex area. We know that there are huge challenges, but we've committed as lead execs in our local organisations, that will be our priority. So those are the three that we are really going to double down on in the RPV arena to try and get over the line within this calendar year, with a focus being on absolutely making sure that we build our services around our patients, we get best value, and as Darren talked about earlier, that we're allocating our resource in the right place. Lots of work going on in the PSB arena. Lots of activity actually, so I'm beginning to get more of a feel for what's happening there, and certainly from a prevention, public health, early years perspective, there is a lot going on, and that's beginning to get some traction across both public services boards. And we had a joint PSB partnership event last week, was it? Yeah. So, and one of the things that we were looking at actually was access to food. So one of the things that that both the PSBs have looked at is affordability of food and availability of unhealthy food, both of which, you know, are different sides of the same coin. So lots of work that we're doing collaboratively in that space, but recognise there are potential opportunities where we might strengthen that. And obviously one of the challenges is there is no funding for PSB programmes. It's about how do we line our work programmes up collaboratively in a way that gives us an outcome that is greater than the sum of the parts. So good work there, and I've attached the 2 annual reports from both Swansea and East Port Talbot PSBs for information for colleagues. And if there's any further questions on that, if I can't answer them, I know someone who can. Regional Joint Committee, not much to update since our last public board. I think we've got a meeting in August. Lots of work in the clinical services space, where Deb and I are joint chairs of the clinical services programme. So there is lots of activity in that place. And again, if there are any specific questions on that, I'm happy to take them. I've also included on page 9 of the report, the annual report on the Swansea Bay City deal. Lots of activity in that space. Obviously, the Health Board are a partner in some of those programmes, the most significant one being the Campuses programme, which I think yes, excellent. I was fairly sure of that, and then I suddenly bottled out at the last minute. So questions to Keith on that, but continuing progress with partners under that programme. RSPPP, so that's the work that we're doing with Cardiff. It is hard yards around the specialised services arena. Probably one to flag is around our inability to get any real traction on the development of the hepatobiliary network. It has proved a very, very, very difficult nut to crack. So we've had to go to a interim arrangement on how we manage patients who have needs under that kind of programme banner that are not ideal, but are in there to safeguard patients at this point, whilst we try and progress plans with the JCC and with commissioning health boards. But it is proving challenging. In terms of our commissioning programme, again, lots of work going on with JCC on looking at how we manage the delivery of the plan for this year, which brings with it both financial risk from a commissioning perspective, which is challenging, but also brings provider risk, because we know that we haven't had all of the challenges that we face as a provider fully funded. So we are trying to maintain that balance. We do have a very open dialogue with JCC which is helpful, but I think there are some very significant challenges in the system, and some of the priorities that are being flagged through the JCC strategic programme are included in the paper for information. Quite a lot of detail in there. Again, from a commissioning point of view, there's an update on our voluntary sector commissioning. We have paused on the timeline for progressing the alliance and commissioning model for the voluntary sector with our local authority colleagues as we address some of the concerns and feedback that we've had from stakeholders. So that is work in progress, going in the right direction, but we need to make sure that we've got that firmly embedded. And the Partnership Board regional commissioning, we have an update there. Again, that is work in progress. And the Area Planning Board, we have received the draft strategy for substance use services commissioning, which has come through a long and very involved programme of engagement with lots of partners who are party to both the commissioning and the delivery of substance use services, and also some of our local residents with lived experience. It is a fragile service. It is something that we're working collaboratively really closely on. It's an area where Deb has chaired the programme board for the last year or so, and I'm stepping into that space for the time being. It is fragile, there's a lot of work to do, but there is really good understanding of the challenges and joint working, and there will be more on that at the next public board briefing. Individual patient commissioning, the two really to flag there are the fact that we are doubling down on how we contract and commission continuing healthcare from a health board perspective, and we've now accelerated the planning work around that to bring the joint commissioning approach that we are proposing to take for Complex Care and CHC with our local authorities alongside that. It's a big ask. There's a lot of work to do there and a very small number of people to do it, but it's something that we are committed to taking forward. So I'll be chairing the internal and the regional partnership board approach to looking at how we do that collaboratively. Nearly on the last bit, sustainability and climate change. It would be remiss of me not to draw your attention to the fact that in June, the NHS Wales Sustainability Conference Awards conference was held in Swansea Arena, and we actually had really good representation from Swansea Bay Health Board. So we had a number of winners. So we had Gwaun Kai, can we say that? Gerwe, thank you. Dental practice. We had cardiac ITU, Kai Velin again, and Annie Hill for this as a sustainability champion. So all four of those were winners, and we also had some highly commended as well. We've got some really great people doing some really great work in this organisation. It's fantastic. And some really good planning support as well, some of the colleagues in my team. So great shout out for them. And finally, but by no means least, the EPRR report. So we'll be bringing an update into board every other partnerships report on where we are with emergency planning and business continuity preparedness and training, exercising. There's an awful lot going on in that space. We've got a very small team, but who work very well with the wider service. And also attached as one of the appendices is the annual report for our EPRR function, which we are required to submit annually to Welsh Government. It's a comprehensive report. If you haven't had a look at it in the reading room documents, I would recommend that you do. It shows you the breadth and depth of the work that goes on within the organisation in terms of ensuring that we are as prepared as we can be for adverse and major incidents. And I think at that point, I will probably draw a breath and hear about questions. Thank you very much.
Well, Marie, that was a very succinct synopsis of a really complex and comprehensive paper across the breadth of planning and partnership. So we bring it here to the board. We started last meeting, as Maria said, and we will continue to refine it. But these are really important areas of the board's business, and it's absolutely essential that the whole board understands everything that goes on in this arena, even though things may just go down to specific committees or branch off. The whole board must be aware.
Yeah.
Marie, did you want to?
One supplementary point, yeah, and it's a conversation that Nuria and I have had, and one that kind of so through audit committee now we are developing a partnerships tracker, which shows who does what, where, and what's their delegated authority, what's the, what are the governance, what are the formal governance arrangements within each of those partnerships, which I think will help to give the board, and Muriel in particular as chair of the audit committee, some reassurance that we have got people acting ultra vires and making commitments outside of their delegated authority. Which brings me on to the other point. One of the points of partnerships, planning and partnership report, is I've always said planning shouldn't own anything. We shouldn't be bringing things for approval. That should come through the appropriate governance routes, through management board, through through our formal planning process. So, anything that requires a commitment from a resource point of view, be it capital or revenue, needs to come through management board, and then needs, if it's not within a delegated authority of management board, then come to board. So I would not expect anything to be decided in partnership fora in terms of committing resources. What we do is we work together to look at how do our processes align, how do we make sure that as partners in a system, we are working together, working collaboratively rather than against it. So it's just to assure colleagues on that basis.
Thank you, Marie. Do you want to add anything to that, Maria?
No, Marie has done an excellent job in covering. I think that the only observation I would like to add is I think that as a board we can't underestimate the amount of resources that actually go into sustaining and maintaining good partnerships and collaboration. I think it's something that we as a board need to be cognizant of in every decision that we make. It's really important. So no, I actually really thank Marie for everything that she's doing on this front. It's really given us the oversight that we need. I think, as we develop it, there'll always be room for improvements, but that's always the case with everything we do. We learn as we move forwards, but I think that we do need to appreciate the amount of resources that good partnerships require.
Thank you, Abby. Yeah, that's really helpful, Muriel, because you have to be really conscious about building those relationships and maintaining those relationships, and they can go very quickly if trust is broken down. And you recall when we did one of our board development sessions, one of the things we talked about is doing an annual check of the health of our partnerships with our partners. We will build that into our work programme to make sure we do that. And Good Governance Institute have given us some ideas about how we might do that and check with our partners so that we can build that into our cycle of organisational development and design, which will be really helpful. Thank you, Chair.
Thank you. Rena, you wanted to come in, and I'm sure you're going to welcome the pause 6.2 on Alliance Commissioning for the Voluntary Sector. Let's have another look at that. Rena?
Sorry, I am having difficulty with the connection, but can you hear me all right?
Yes, fine. Did you hear me?
Yes, I was struggling to hear that, sorry, but I'm fine now. Yeah.
Please come in, and I'm sure you're going to comment on 6.2, the pausing of the Alliance Commissioning model for the voluntary sector. So that am I right?
Yeah, I was concerned that not that we are proceeding in the sense that we are going to a different model, but that there seemed to be a lack of understanding within the third sector and within Swansea CVS on why we are moving, and a lack of understanding of the benefits that could be gained. So I think, Marie, there's obviously a bit of a communication gap there that I think we need to be aware of. And what they did say particularly was the amount of time that it had taken to establish the framework arrangements, and that had taken a long time to bed in, and having got that. So in a sense, I suppose we need to be aware for small organisations, which often these third sectors are, which is obviously Nuria is aware of, changes can be quite problematical for them. But I was just going to make a general point, Shell, as well, that I really feel the wealth of information in this report is excellent. So thank you, Marie, because I feel we were missing out on understanding how all of these partnerships can impact on what we're doing. And if we really want to embed like population health across the whole of the health board working, we're going to have to do it in conjunction with everybody else who's working in this area. And this is so important then that we recognise the role of all the other organisations and how important it is that we are good partners. Thanks.
Thank you. And I'm sure that'll be well received. Marie, by you and your team.
Thank you.
Any key points for? So we've got a lot to consider and support as well, I would suggest, Marie. So you set up the approach to developing the 26-27 plan. So we look for support for that, the approach taken. And then the area plan, the priorities for 25-26 for the RPB for the 3.
Yeah.
Is that right?
Yeah.
Older people's frailty, collaborative mental health services, a collaborative approach there, long-term and continuing healthcare. So Steve Hunt and I, as the chair and vice chair of the RPB respectively, are meeting on Tuesday of next week.
Yeah.
So that's a really helpful timing for that. So are we happy to support those priorities for the remainder of 25-26? So my system has just decided to
just had a panic.
install something else. So, we got. They're in the middle here. Oh, hang on a minute. I think I've got it.
There you go,
Yeah,
there you
I
go.
got it. I've got it. I think I've got it. So, we got it there. So where I got? So
That's
we
all
did,
good,
so we've done annual plan, RPB. So we do have statutory responsibilities in respect of our work with the PSBs, etc. So we just give our continued commitment really to working both with our statutory and non-statutory partners on this agenda. Then obviously the tightening up of the governance around our regional joint committee, that's important. And we'll take that to the next meeting on the 18th of August. So we consider and acknowledge everything that's happening in the Swansea City Bay Feelers. Then the actions to progress all our arrangements there. And particularly we want to support the work around the climate action plan and the whole sustainability agenda. And then the priorities and the progress as you've set them out for the EPR programme, Marie, and to receive regular updates on that because that is so important.
It is, yeah.
That's okay. Thank you very much. So we are approaching our lunch break, but are people happy just to continue to take 3.4 and 3.5 before we break so that we do conclude this section? Is that okay? Because we have taken a strategic equality plan previously. So this is the reworked plan following conversations at our last board. So Jo, can I hand over to you for that then?
Yes, no, that's great. So at the last board, we had the We All Belong and a lot of detail about how we developed that with through engagement with both internally and externally. The question was asked around being clear about the statutory requirements for that plan and also being clear about the difference between equality and equity and what that meant for us. And that chimes very well with all the conversations we've had today, really, doesn't it? About the, I think there is a real commitment and a real enthusiasm to actually to reduce inequalities and reduce inequity. And part of that is about actually making that decision about whether we are responding equally to different populations or whether we are responding differentially depending on their need. And that came up, didn't it, in terms of the screening. It's come up in a number of other things. So it is this about being clear that the premise behind that is that we will respond differently to the needs of different geographical or service groups in a way that will enable us to reduce inequity. And in some ways, that's a bit different from what we've done in the past, which is we've tried to reduce everyone's inequity. This is about proportional response around that. So I think we thought it was important that was really highlighted because that is a different approach and that has different connotations and implications around that. Hopefully what the paper has done is made it clearer for people about what exactly our statutory requirements are as a health board, how we are proposing to deliver that through the strategic equality plan, bearing in mind this is a very different type of beast from what the organisation has produced before. Hopefully it gives assurance to the board about actually it meeting the requirements of what a SEP should do. And I've put some matrices in there to try and help people to relate how our objectives relate to our strategic objectives as an organisation, and also how they apply across different protected characteristic groups. So it kind of feels like it's quite a complex set of matrices that we're trying to balance with this plan. But hopefully the information there can demonstrate how we're trying to do that. We are keen that we've committed to reviewing our action plan, particularly come September, October time, so that it can form an integral part of our annual plan of going forward, because it was felt that that was one of the things that was missing, was our kind of read across. So this is what we're hopefully have tried to align in this paper, so that it's clear for board members about how it, not only it exists in isolation, but how it relates to all of the other components. Happy to take questions, queries.
Thank you, Jo, and thank you for all the additional work that's been undertaken since the May meeting. Maria, did you want to come in there?
Absolutely. The first thing I want to do is recognise all the hard work, Jo. I think, it's hugely improved, and I know that it has been tested against our statutory requirements in relation to the Equalities Act and Welsh-specific duties, because I think it's important for us to remember that we do hold Welsh-specific duties on this agenda. I think that my key question is for us as a board. So I think that we need to 100% embrace this with our eyes wide open. And Jo has touched on this. The strategy makes a big play on the choice of pursuing equity, not equality. And we know that, as Jo has pointed out, we are traditionally, the NHS has been rooted on equality, that you get the same service regardless of background or geography. So I think that for me, moving to that equity means shifting resources, like we touched upon earlier, support and service provision to those individuals or group on geographical areas that we know need more, and we have tested on that previously. So the question for assurance is for the executives, and it is about that they recognise that in improving the SEP, we're making a transformational ask in terms of the organisation, our clinical services, and that we are ready to see that through.
Thank you, Nuria. I'm going to leave that with Abby for a little minute, and Pat, ask you to come in.
And I agree with everything you said, Maria. I just want to question a couple of specific sentences in the report. First is at the bottom of page 9, where it says most people will have at least one protected characteristic, and lots of us will have more than one. Actually, everyone has at least 5. Age, sex, sexual orientation, race, and religion cover every single human being. So a white, middle-aged, agnostic, straight man has at least 5 protected characteristics. And I think that's quite important, because we tend to think of race as meaning Black people, sexual orientation as meaning gay people, gender as meaning women. It doesn't. They all cover everybody, and it's really important that we dismiss that myth. The second one is towards the top of page 13, where it says ethnicity varies across Swansea Bay, with 8.6% of the Swansea area, 4.6% in the Neath Port Talbot area. 8.6% of who?
Right. Yeah, so, the overall population.
No, I don't mean, but when it says 8 point ethnicity, again, is so 8.6% of white people living.
And just on that point, we think that's underreported. So there's something about
it is that you're saying is
yeah. We need to explain that. Yes.
The population. Yeah. It is it's the breakdown of the population, which we can be a lot more specific.
Yeah, we can. That's really helpful, Pam.
Tina.
I just wondered whether we take this to a board development session, because it cuts across quite a range of committees and portfolios. So we've got the population health, we've got patient experience, workforce experience.
Yes.
And I just wondered, because we just need to make sure we've got the right governance oversight and accountability for this, don't we?
Yeah, Hazel already has that on our board development programme because, as Nuria says, this is a very different approach for us. And I think, you know, in terms of readiness, well, I wouldn't say we are. And really, we're accepting the principle of this as part of our plan. Then how we get ourselves ready is going to be the next stage, Nuria, I think, because it is transformative, as you said. Any other points or questions? Joe, did you want to come back on any?
Yeah, just to pick up that transformative point, because I think the other thing, and you'll have seen it in the risk register, so we have made progress in developing that integrated impact assessment with the which was in the action plan. In the first stages of actually trying to make sure that we have something that pulls together all of the requirements across the piece. And stops different bits of the organisation doing different impact assessments depending on what the topic is. There's more work to be done around that. We're doing that on a very much an action learning basis of applying it in different, you know, for a business case, for a policy, for a service change to actually make sure we learn and make sure that's most appropriate. We have built in things like Welsh language and such like within that. There's further work to do to get it closer to the Public Health Wales integrated impact assessment, because we're trying to have a balance here about enabling the organisation and particularly the board to understand the impacts of all of these changes and make decisions in that light without making it such a painful experience that it's difficult to actually build that up. So that's very much in the work plan and work that we're underdoing at the moment.
That speaks to your point, Tina, because this is an organisational development, culture change piece, really, which the board needs to get its head around first. So thank you, Joe. So can we take it then that everything we asked Joe and the team to do from the last meeting has been done? The statutory requirements, the requirements for the plan, and how what we are proposing measures up to that. So we can approve the plan in principle as set out, recognising that we as a board need a specific development session on what does this mean. It's a transformative plan. We will need to understand our state of readiness, the whole resource allocation agenda. And down here, a long list of things now in terms of taking away from this meeting around the whole allocative process. Once we know how much we're getting in from Welsh Government, what do we subsequently then do with that? Thank you. And then we will also be looking at, Joe, you've said you've already got a specific action underway, the integrated impact assessment work, which we can bring back as part of the board development session. Be happy with that. Thank you. And please convey our thanks to everyone who's been engaged in the mission. Thank you. So, Aaron, you are now between us and lunch.
Consider them. Thank you for putting this report in this part of the agenda, because it could so easily be in a governance meeting. It actually does talk to our strategic direction and our partnership work, so it's placed well. So thank you for that. Obviously, it is before lunch. So the business case is brought before the board today for approval, submission to Welsh Government for consideration for funding, and the case has been through our Performance and Finance Committee and the Regional Partnership Board as well, and then received endorsement in both of those fora. I'd like to record my thanks to colleagues in the mental health and disability team for the work they've done on this, and so much other work is going on at the moment, and in the reading room for board members, they are all the detailed documents you'd expect for BJC standard production, which are available for colleagues to scrutinise. The case is seeking capital investment of just shy of 10 million, 9.9 million from Welsh Government. This is via the Regional Partnership Housing and Care Fund rather than traditional health route. So it's coming through a different capital route, hence the involvement of the RPB in the discussion. This is a partnership strategic piece. And what it will do is redevelop the existing Danny Dairy complex to provide fit-for-purpose medium-term accommodation for people who identify complex needs and behaviours, people with challenges. And for you to know where it is, it's next to Poynera Learning Disability Unit, just in Morriston on Placement Road. And the existing building has been closed indefinitely due to the condition of that. As a result of that, patients have been placed in alternative learning disability accommodation within the health board, further field, simply because that building was deemed to be not fit for purpose. And what we have before us today is a plan to build a flat-based solution, which will include a bedroom, an ensuite facility for each resident individually, a living area and a personal outdoor space. And for those of us who have visited our learning disabilities facilities, you'll note that this is a step change in terms of provision of accommodation compared to some of the areas we've got. So this suggest this is the start of the journey rather than the end of the journey in terms of how we provide accommodation to these vulnerable groups. Overall, the investment will expand the health board's offering for these patients who require these services, and will facilitate repatriation of the patients who are further afield and bring them closer to home, which is incredibly welcome. And as part of that, the broader offering of learning disability models will be modified as this facility comes into place. I stated earlier, this has been through both partnership and local governance, and also planning permission has been granted by Swansea City Council as well, so we have available planning to progress this at pace. As I said, the case requires £9.9 million worth of capital investment. The work can start upon approval of the case and could be completed in quarter 2 of 27-28. It requires the demolition of the existing facility and then the rebuild. And from a revenue perspective, it's likely to bring a case which has to wash its face from a revenue perspective, but that is as a result not just of Dana Dairy provision, but a look at workforce across the disabilities. And so what I'm asking the board to do today is to move the case for submission to Welsh Government, but also should Welsh Government find that approval to be satisfactory, me to then let a 16-month contract for which all the background work has been done, the preferred provider has been selected, but due to commercial sensitivity, I'm not bringing that to board, and that provider will only be notified should the case be supported. So it's a two-pronged. That's not more.
Thank you. And Darren, I think you've answered the question around how could it be revenue saving, because Andrew would ask that, because the staffing doubling, really, but you're looking at the whole workforce across the piece.
We've redistributed, we're redistributing back, and we've tested that revenue piece. You'd expect me to be the case at this stage.
Thank you, Andrew. And we also had about future proofing it, because that's something I know Pat was interested in, performance in finance, and then use of potential land future in terms of additional expansion on the basis that this will help existing services, but what's the potential?
So that's fine. I'll do the potential first. The Finera site is constrained by parkland and residential areas, so it's not a significant site of opportunity, but there is flexibility to increase on that site. That's subject to planning permission, so there's an opportunity there. And in terms of design, this is contemporary design at this stage, but we know when we moved from our institutional care to the bungalows, that was a seismic shift. I think this needs to be done in coordination with the broader community models as well. So this is absolutely a need for now. But as colleagues in disabilities, I can't say that today, in learning disabilities, works with their strategic direction, I think we'll see more and different innovative solutions based on the whole flow of care for these patients rather than just where they need it.
Thank you, Darren. Are there any questions? Jackie?
I just had it's lovely to see investment in learning disabilities. I have to be honest, and being familiar with the building itself, this is really, really good news. I just wanted to pick something up in the paper. Obviously, this proposal doesn't increase capacity in terms of the number of patients, but we do know that the need in terms of that patient population is going to increase. But obviously, option 4, which is more expensive and just the maximum, does both provides new building and kind of increases potential capacity for patients. So don't really know what my question is, but in terms of are we doing the right thing in terms of the future demands that we know are going to be there for the service?
Not for a response, and perhaps we can pick up the detail outside, Jack. But I think from my perspective, we know that I think it's Penny, if I may get the name on, is looking at the strategic direction of learning disability services for the 3 health boards that we serve. Actually, we need to look across that, and across that work, we will look at where the appropriate accommodation and that demand would be. And I'm not sure that everybody in a bungalow is absolutely appropriate either. So I think we'll lead it to the clinical leadership on that. But effectively, then this is one jigsaw of a long development of really important innovation in terms of learning disability care.
We are going to be looking at learning disability services, Jackie, alongside the mental health that we've begun. So thank you. So on the basis of the explanation we've had from that, are we happy then to approve, firstly, that we apply to Welsh Government for the sum? Yeah, and then subject to that approval that we let the 16-month contract. That's correct. Thank you very much. So on that note, we will break for lunch and we resume at 12:50. Please. Go,
to us nine as well, so it's to get to the legislation and take the deciding.
So no, Bob, this is our afternoon session of the board and the session in which we move into the 25-26 year. So we look at delivery, quality, safety, performance and resource matters relating to our current position. And in this section of the agenda, we always take a number of committee update reports. And we begin this afternoon with our digital data research and innovation committee key issues report. Andrew, I'll turn over to you, please.
Yes, so on this report, there were 3 alerts from the committee. There has been a further committee meeting since this one, but the alerts arising here, first of all, was around financial management. And that was recognition that there was budget in money for vacancies and other things. And we wanted to see a better plan which reflected the fact that we had demands for the digital strategy to be moved forward. And we wanted to see the money allocated in a way that puts forward the digital strategy. So I believe there's been a meeting, as Pat can tell us, with finance to look at reprofiling and understanding where the spends were and how they could be applied to projects that needed moving forward. The second one was around clinical coding, which we've given a good airing this morning already, and essentially it was those issues that we talked about earlier on that we discussed. And thirdly was around records management, and in particular 2 issues. One, making sure that the policies around record management applied not just to the clinical notes in acute, but also in mental health and other notes that are kept across the health board. And that has now been, those policies have now been updated, and there's a plan in place to make sure that we are assessing the quality and the positioning of those notes as well. But along with that was the issue of subject access request, and the fact that because we still have a lot of notes around the place, that was becoming harder for people to respond to the subject access requests. And there's now a project in place and a plan in place to look at increasing the performance of the subject access request and try to bring that together into a system that makes it less paper-based, but an easier system to manage electronically.
Before I ask Matt to come in, Darren, can you remind me when the board approved the data and digital strategy? It was approved on the basis it was revenue neutral, isn't it?
It was, and then we would explore how we build through the through planning cycles.
Yeah. Thank you, Darren, for that clarification. Matt, over to you.
Thank you, Chair. Yeah, so that, I guess it's the financial challenge, isn't it? You know, we've got ambitions as a health board to accelerate our digital ambition. We set that out in the strategy, as you just alluded to, but we know we've approved that strategy in principle with further work to do on the financing forecast. I guess the paper particularly picked up on this year, and we do have a number of vacancies in the digital directorate. That is a direct result of holding back on advertising vacancies to help the bottom line of the organisation. Some trouble filling technical roles as well, because they're well sought out there, not just in the rest of NHS Wales, but across the public and private sector UK wide. So we do struggle to fill certain technical resources, but the main challenge, I guess, is one of, do we continue to spend our money in digital to progress the plans that we have, versus, you know, how much we need to save on that to help the health board's position. And that's certainly a challenge for this year, and one that Darren and I and the teams met on a couple of times. We haven't had that meeting yet, Andrew, that you alluded to, because it's not just about this year, is it? It's about that commitment that we've got to the strategy and how we plan initially the next 3 years of the IMTP, so that we start to get towards that level of investment that we've set out in the digital strategy. So it's still to be, the challenge is still to be met, I would say. We are identifying risks at the committee pertaining to various projects where resourcing levels aren't where they need to be. At the moment, the IMTP is fine. We're progressing against all the projects as planned. We're keeping a careful eye on that as we progress.
Was there anything you wanted to say there before I open it up? No. Comments, questions to Darren, please come in.
Yeah, I just want to firstly recognise the nature of the challenge here, because this is one of those things, it's a bit like the allocated conversation we had earlier. If we don't start doing something, we won't get improvement downstream. So I think the offer for me to work with the team is to consider what would be immediately benefits realising in terms of the strategic shape of the plan that you've got, build some momentum around resource we can then move around the system. So we're not exposing a cost burden we can't realise. What we're actually doing is starting to get more and more momentum in terms of resource reallocation in the organisation. And the MATS group is £800,000 underspent already, and that's part of the offer. We need to help the organisation, and everybody's feeling the same strain. So we want to single out the director, but I think there are ways that we can probably start to look at a slightly different way to help get some things going, whilst maintaining the grip of control that I'll talk about shortly.
Thank you, Darren.
Thank you. Jean?
And one of the things we had discussed, Chair, was the return on finance from the group last year. And my question was, which Matt knows clearly, why did we return monies when we had resource vacancies? Why did we not have that business conversation to say, can we use some of that money to fill some positions? So maybe that's something that you can help us look through.
I'd be happy to do that and perhaps include Jean as well.
The really important point, Jean, so we'll take an action of dabbling on that too. Any other comments or support? So thank you, Andrew. And as you said, we looked at clinical coding earlier and the backlogs around subject access requests as well. So we asked the committee to sort of very robust oversight on that. Thank you. So Jean, may we turn to you now for quality and safety, please?
Yes, thank you, Jan. This is a report from May. We have had a subsequent meeting, but I haven't brought the information from that meeting because there's a lot more that we want to fill out in terms of reporting, in that we've taken, as I said at our last board meeting, we've taken a very stringent view at how we're reporting, not only reporting, but how we're analysing information that we're getting in the reports, what the quality of that report looks like. So we have taken quite some time to think about how we restructure the reports going forward. And I think Liz will agree that the last session we had was really meaningful and reports were of a better standard. I know Keith articulated the same comment. So this one, we wanted to alert the board in terms of the patient story for Neath Port Talbot, which unfortunately wasn't as good as an experience as we heard this morning. From that, it was a baby loss, unfortunately, but from that story, the discussion highlighted the value of compassionate care and the need to share best practices across the service groups. And improvements since then include communication and language training packages, the formation of the baby loss support team, the named nurse on admission, and greater recognition of the time that families need for their concerns to be addressed. So that was a real learning opportunity for everyone. The stroke performance, the committees highlighted that the current standards for stroke patients were not being met, and that the need to review the improvement plan in the Quality and Safety Committee meeting, which we did have a look at in the July meeting. And we referred to performance and finance out of that meeting as well. The request to provide to provide us with a detailed information on the allocation, usage and impact of the funding that we've received. The next alert was the death certification reform, which we've also given assurance about, which was the delays in the death certification process following the change that was impacted by legislative changes last year. And we had a really good update from Raj, who outlined what the differences were, how the resourcing looked different. So we then took assurance and give the board assurance that all necessary actions to address and resolve the problems resulting from the new certification process were underway. And I think that was it. If you want me to just touch on the 4 health board risks that we are looking into more diligently, which is the access to unscheduled care. The current score is 16, but if we fail to provide timely access, then the impact on quality and safety of patients is really expensive. So the next one is planned care. That's the risk to patients if we fail to diagnose, to treat in a timely manner. So that's really significant for us in terms of patient care. Access to cancer services, the backlog created by the pandemic. So people with suspected cancer at the time, it's created an increase in referrals to health board, which is greater than the current capacity that we've got for proper diagnosis. So we'll be having a deep look at that too. The last one is the CAMS failure to meet required standards of performance. The workforce deficits in the team across all staff groups, including the medics, psychological therapies and nursing. We need to pay cognizance to that severe risk as well.
Thank you, Julie.
So those are some of the things that we're looking at moving forward.
Liz, would you like to add to that?
I think our next update, which will be the July meeting, will be in much more detail, and some of the things in there we've already picked up through. But as Jean said, we are working to really look at the function of that committee and how it provides information and therefore assurance or not to board. So I don't think there was anything else from that May meeting particularly.
Thank you. And I think the learning that would be applicable to the wider piece we're doing on the improvement plan for maternity leave. What it is applicable across the piece there. So can I open that up? Any comments, questions? Deb, was there anything you wanted to come in on at any particular?
No, I don't think so, Chair. So I'm joining the team on the Body Safety Committee now for when they leave me in there, so we can pick up some of those items directly. The stroke referral came to Performance Finance Committee and this committee this week as well. So we had a good wraparound on that. We had good representation from the stroke team and we've got a good way forward with that as well. So
we've seen some improvements, haven't we, in terms of processes around stroke services. Yeah, that's good. Thank you, Deb. Nora, did you want to come in?
It's on observation on the compassionate care element of the report. I think this is hugely important, taken into account some of the recommendations that have come out from audit, maternity review, etc. So I think that for me, it's getting that picture and view of what we're doing in terms of trauma-informed services and fulfilling all of our interactions with every patient that we have. So it's that kind of work that look like if there is anything ongoing that you can highlight at this stage.
So I think there's a huge amount to do, and when you explore trauma-informed care, there's a lot that we will need to do to support our staff to enable them to really understand and put themselves in that other person's place, really. So I know, particularly around the maternity improvement plan, there's particular work that we are doing, but acting on the discussions that we've already had, there's a huge piece around staff education and engagement, but it's also about learning from organisations that can help us with that. I don't know whether you remember when Denise Chapper was here giving us the feedback on the review. She talked about the harmed patients group. So I've already been in touch with them and set up some time where we can understand what they do, because they don't yet work in Wales, but they are keen to do so. And this is of course patients that come together or those that have experienced poor care. So initial contact made. I think they'll help us to shape the right focus of the education and training for our staff. Not just them, there are others too, but I'm really keen to hear from them very soon.
Any other comments or points? Thank you very much, Jean and Liz, for the way you are sort of reforming the committee now, and we look forward to the next report in September. So we turn now to performance and finance, and in our price absence, I'm going to ask Steve, if you can take us through really to earlier meetings of performance and finance committee, but also the one this week to inform the subsequent discussion on finances. Thank you, Steve.
As you say, Chair, there are two reports in the pack, but they've been more or less overtaken by events now. So the May report has an alert on the month one financial position. And the June meeting, there's an alert on there's going to be a theme here, I'm afraid, month two financial position. So I move straight on to the meeting that we had on Tuesday of this week. And there will again be an alert on the month three financial position and the recovery and sustainability update that we received generally. The principal reason is that there are two basic reasons. There has been a variable pay cap instituted, but it's not really taken hold yet. And variable pay in month three remained too high. And soft data, I don't have any actual data yet, but Darren may have a contribution to make. Soft data is that the variable pay cap hasn't really taken hold in month four either, which finishes today. So may see that month four going in the same direction as the previous months. There also remains a gap between the savings target that we have set and the actual savings identified. And still some of those savings that have been identified have red rag ratings. So they are acknowledged as being difficult to achieve. So this remains an issue for the Performance and Finance Committee. So that colleagues are aware, Performance and Finance Committee review in detail the finances, both historic and projected, each month. We meet informally in the intervening period as an RNS oversight group. And I know the chair of the Performance and Finance Committee meets with Darren quite often. I meet with the director of RNS, Brian Owens, quite often for one-to-one updates. So lest anybody suggests that the board is not all over the finances of this organisation, be aware of that. But we'll see in the financial report that Darren's going to bring to us shortly that there are still some big challenges and a lot of work to be done to achieve the target deficit for the current year. So those are the alerts. There'll be a specific alert also from the meeting this week on the Morriston Hospital financial position. Excuse me, both in respect of their savings gap and their variable pay performance. Performance and Finance is not only a finance committee. There will also be an alert coming from this week's meeting on stroke performance. There's partly a financial problem there because some of the funding that was allocated, earmarked, I should say, last year, didn't get spent. But we do not have a 24/7 stroke on-call rota, and our performance in respect of two key stroke treatment areas. So I'm probably going to mispronounce it. It's either thrombolysis or thrombolysis, and mechanical
Combination of both.
Okay. And I did Greek, but it was a long time ago. And mechanical thrombectomy, I think I got that right, where our rates are well below target levels, and that's frankly not a safe position to be in. So that will be another alert. So I'll stop there.
Thanks. Deb, can you pick up the stroke issues when we get to the integrated?
Certainly, yeah, I've got notes of them as well. Thanks, Chair.
Thank you very much. So I'll open it up for questions on the financial analysis, really. that PFC always does in detail. And Steve, you usually give the board advice as to whether any level of confidence has changed since the last meeting. I'm taking it from what you said that there has been no change in confidence levels.
No, the only thing I would say, and Rena mentioned it in the pre-meet that we had, we were assured by the fact that the Deloitte team came to the meeting, and they impressed us with the speed with which they got their feet under the tables, and the sort of analysis that they were bringing to the meeting. So, you know, whereas formally the level of assurance hasn't changed, we're a little bit more optimistic than we were, let's say, a fortnight